I've got a sudden surge of Insta posts. I'm so impressed. Actually, after 8 o'clock, you guys can send more. So we move on to our next segment, all right? So it will be the Fight the Fever, how to maximize your performance in the examination. And this is quite an important part of your learning process. And the chair for the session would be Dr. Kamaljeet Singh, sir, and Dr. Bhavna Sharma, ma'am. I request you, ma'am, to please take the dais. Sir, idhar, sir, wherever, sir. Please. So let's start with the first talk, and that would be how to balance acquisition of clinical skills and theory knowledge during residency. And I request Dr. Rajendra Singh Chauhan, sir, to please come on the stage. Sir is the professor and head of department of ophthalmology at Regional Institute of Ophthalmology, Rohtak.
Respected dignitaries at the dais and off the dais, and my dear students, I'm Dr. Rajendra Singh Chauhan, and for next 15 minutes or so, I'll talk about how to balance your theoretical knowledge with your clinical expertise. Hello. So are you ready? Okay, fine. Residency is a roller coaster ride. Why I'll tell you, because after MBBS, after the UG, when you enter into the residency, and all of a sudden you find yourself in a cobweb. You don't know whether you have really done well and you have entered to the right place. Because I remember when I joined ophthalmology, my teacher, Dr. Khurana, asked me, you came by choice or by chance? I still remember those words. So you have to come by choice, not by chance. That is one thing. Second, less was in the punctum. So when she will open the eye, the hair will go down. When she will close, because of pressure, it will come up. So that is the importance of slit lamp examination. Learning curve under microscope, especially depth perception, is very, very important. After some time, the resident will feel almost 1 year has gone and now I have not started doing operations. And all of a sudden, that student will sit on the microscope and she or he will not be able to perform surgery because there is no depth perception. And then the various instrument and equipment are entirely different. They had never been seen during your UG period. In MBBS also, because ophthalmology is a small, minor branch, so nobody is interested. Everybody want to pass medicine and surgery. And that is why they have not seen, or we also don't try to show them. Have everybody gone to, anybody had gone during MBBS to see OCT or Pentacam for that matter? Nobody. Not even the faculty will show you, because they will say, oh, this is not of your use. The MBBS level, you should know what is Snellen chart, what is ophthalmoscope, what is indirect ophthalmoscope. That's it. And all the procedures are daycare procedures. That is why ophthalmology is different. Now, even the curriculum is also divided into cornea, retina, oculoplasty, glaucoma, cataract, pediatric ophthalmology, etc., etc. So there are so many specialized branches, specialized area which are not correlated with each other. Now, the challenges during residency is that you need to acquire clinical skills. Very, very important. the first year resident comes, in 1 month he is not able to see slit lamp only, because he doesn't know what to see. Because you will be able to see only when your mind will know. And you don't know how to see. Like in cornea also, they will just focus the light and there will be sclera and cornea and AC and that's it. But when you know the theory, when you know what are the types of rays, how you have to see the cut sections, magnifications, and binocularity, and then you have to scan the anterior surface of cornea, epithelium, stroma, endothelium, anterior chamber, angle, pupil, switch off and switch on, you see the pupil reaction, and then coaxial and red glow. Until unless you know all these things theoretically, then only you will be able to see practically. If you don't read about slit lamp examination, you will not be able to see anything in slit lamp. Second is surgical skill. Now, to learn surgical skill, you need to do a lot of practice surgery, and that is why wet lab are there in ophthalmology. And even in wet lab, there are plastic eyes, there are goat's eyes, and now artificial intelligence based machines through which you can do CCC, etc., which is in R&R hospital. There is a beautiful machine. So, even away from that, there is one more thing what we are trying with our resident is, we put that cotton ball inside the glove, and then we make size of cornea, and we ask the resident to pass 16 sutures, 10-0 suture under the microscope, apply stitch 3-2-1, 4-2-1-1, 3-1-1, etc., so that radiality will be seen, the tensile strength will be seen, hand-eye coordination will be done, and it is not messy. You can do this in major OT, main OT, and without any problems of asepsis. And that is how the surgical skills are attained. Thesis is another one very important issue which is not liked by residents, and because it eats a lot of time, because you were never trained how to do research, and that is why, and this takes your 1 year, full 1 year, and it is entirely different. There are research methodology you have to read, and then statistic. These days people, the students hire the statistician, they charge somewhere some 5,000 to 10,000, I don't know whether it is correct or not. And then of course the examination. Now examination is also after the 3 years, but probably it is incorrect, because for 3 years, because to learn ophthalmology, you need to be assessed and examined at a regular interval, not at the end of 3 years. Because until unless there is fear of examination, you don't try to read. The brain is not receptive. Now, how to balance theory and clinical practice? What theory is? It covers what information, what is there, and what clinical knowledge is, how and why. And this clinical education is the core of the medical education curriculum, and theory is the complementary component. So, the balance is the key to the successful residency in ophthalmology. I again repeat, in ophthalmology, because whatever clinical skill you learn, if you read before, you cannot perform. If you are doing, for example, fluorescein angiography, and you do not know at what interval the photography camera will be clicked, you don't know anything. And for example, pentacam, that girl was telling very nicely that description of pentacam. Until and unless you know the details of the pentacam, reading out itself becomes very difficult. Every procedure you do, take simple procedure. Take simple slit lamp examination, take simple indirect ophthalmoscopy, take simple microsurgery, take simple appellation tonometry. All these procedures, that is what I always say, these are the basic fundamental of modern ophthalmology. If you want to see slit lamp, you need to read about the manual of the slit lamp, what to see, where to see, and what is seen where, everything. So other clinical skills, whether For example, one clinical skill is surgical skill is incision to be given in calagion. Very simple. Simple procedure. What is difficult in it? Yes, it is difficult. Why you want to give vertical incision through conjunctival side and why you want to give the horizontal incision from skin side? Until and unless you read the theory that orbicularis oculi is circular, the veins and arterioles and nerves are running circularly, and you don't want to cut them, then only you know that it has to be given horizontal. And why it should be given vertical? Because you know the meibomian gland is running vertically. So you don't cut the other meibomian gland. The same is true if you do not know what is the difference between stye and calagion theoretically. That calagion is a chronic inflammatory granuloma of meibomian and stye is infection of the disease. So you will go to the right approach. You have to puncture the stye and you have to give incision in the calagion. That is what is the importance of the theory. Now, the fundamental of modern ophthalmology. I assure you, if you just remember these four things, these are the fundamentals that every patient need to be seen under slit lamp and every fundus need to be seen with indirect ophthalmoscopy. There is a very good article in Survey of Ophthalmology by Boyd. He has written 60 pages article. It is written, until and unless you spend 60 hours doing indirect ophthalmoscopy, you cannot master indirect ophthalmoscopy. So it is not that simple procedure. Every surgery has to be done under microscope and every IOP measurement has to be done by A-plane tonometry. A-plane tonometry is also very, very important during residency period. So how to proceed? First year residency, because usually there is no clinical rotation, and read anatomy and physiology thoroughly. Keep a clinical handbook of ophthalmology always. Observe your senior and assist procedures. Second year onwards, read clinical ophthalmology and perform procedure under supervision. Now, with every specialty posting, you have to read about those. Like in retina, you have to read about retina and then only proceed. Eyes can only see what mind knows. That is what is true. And you have to keep a record, you have to keep a logbook with you, and you have to record all interesting cases so that you revise them. And whatever you read today in the morning, if you revise by night, 80% will be retained. If you revise next day, only 20% are retained. So, the improvisation in teaching methodologies, problem-based learning, and integrated teaching programs like radiology, pathology, dermatology, all are related to ophthalmology. There are so many examples where you feel that if there is small pustule on one side of the head, patient is complaining of pain, and actually it is herpes zoster ophthalmicus. So it is, otherwise you can send the patient to the dermatology. So it is also related to ophthalmology. Now take home message is that balance is the key. You have to read theory before you embark upon to become expert in your clinical and surgical expertise. Read before and after you see a patient always. Assist before you perform a procedure. Perform under supervision before independent. Discuss more and more with your seniors. Senior can teach you things which even 100 books cannot tell. I think that is enough.
Thank you very much, Professor.
Okay. Spend as much time as possible examining ward patients and actively participate in all academic activities like this academic activity. Thank you very much.
Thank you very much. Now, may I invite Professor Suresh Kumar? Professor Suresh Kumar?
Very good afternoon, respected chairpersons and dear students. At the outset, I am grateful to Dr. Santosh for the invitation. And the topic for my presentation is what I would look for as an examiner in a long case presentation. Sorry for little disturbance in the sequence as I have to go early. So that was the reason. So before going with the talk, I will just tell you a brief episode during my examination. So, like all the students, all of us are stressful on that day. So it was year 1995, and we were in the OPD, and then a message came that examiner have come. And then there was a call. Examiner has called all the students. We were 6 residents. And when we went to, Professor Amod Gupta was head of department at Advanced Eye Center at that time. And second internal examiner was Professor M.R. Dogra. And when we went to Professor Amod Gupta's room, Professor H.K. Tiwari was sitting there, chief of RP Center and top retina man in the country. And unexpectedly, we were never expecting that he will call us. And then what he said, it was music to our ears. He said, I am here to help you, so please help me so that I can help you. So then with little help from our side, he kept his promise and gave us enough occasion to celebrate at the end of the day. So I think all of the examiners sitting over here will agree that they are positive, they just want to help the students, provided the student don't make major blunder, which nobody can justify on that day. So if you are cautious, if you are act responsibly and go the halfway, the battle is won. So coming to my talk, qualifying Doctor of Medicine or DNB exam is a major but challenging milestone in career of any student. And examiner, what is our stand? Basically, we want to ensure that students can keep the patients safe and manage most cases with reasonable competence. That's what we expect from the students. And qualities an examiner look for in examinee is sincere, hardworking, polite personality. He has to be compassionate, knowledgeable, and good human being. These are the qualities which should be there to make you a good doctor. So first we have to be good human being, only then we can become good doctors. However, the qualities we can assess in a practical examination is knowledge. So whatever long, short cases we have or viva voce, we check the depth of knowledge, and then attitude of the candidate, how candidate present themselves, tone and tenor of speech, their body language, how candidate listens to the question and their response, and presence of mind. So this is what we can assess, and then skill. We always tell the examinee to do something on slit lamp like gonioscopy, indirect, then we examine how they are doing, whether they are following a particular sequence, confidence level, and whether they are highlighting important anatomical landmarks, and technique, how they are doing. So this thing we can assess during practical exam, but unfortunately our system is not perfect, and we cannot assess these qualities. So for these qualities, we have to take feedback from your professor and head and senior professors of the department who are also internal examiner. So, but we have to continue with this examination system, and we have to use it judiciously to get right information about the candidates till we get a new, better system. So in current system, I think theory will be discussed by Professor Bhavna, and practical will be discussed by Professor Kamaljeet. So coming to practical examination, the practical is always little difficult than theory. Because in practical, we have to think, formulate the answer, and speak at the same time. And honing the case presentation skill is vital, very vital in practical examination. So component of practical examination, Professor Kamaljeet will be highlighting. And then coming to long case presentation. So long case presentation, I will say, is key to your exam. If you do well in long case and you are able to impress examiner, half the battle is won. So focus on long case, spend time. We always give half an hour, 45 minutes to 1 hour for preparation of long case. Always write every detail. Don't miss anything. Because suppose you fail to tell while you are presenting the case, you can always support that it's written. So if you have written and examiner misses when you speak, so examiner will agree that you have spoken. So writing every finding, whether it's history, clinical examination, always write differential diagnosis. points in favor of one differential diagnosis, point against that differential diagnosis. If you have done workup like this, no examiner will ever, will be turning against you. So, and then in history, all of you know demographic data, chief presenting complaint of the patient, then history of present illness, past illness, family history, physical examination, and ocular examination is key in our specialty. We have to have detailed ocular examination. So I'll be just showing a case of NVG as prototype. So I will be showing few slides, and what are the important highlights in your long case will be highlighted in this. History of present illness, you elaborate chief complaint. So like in this patient, if there is history of decrease in vision since 3.5 months, so you have to tell how much visual loss was there at the time when patient had the problem, and then whether that loss was significant or not, whether it was mild loss or severe loss from the beginning. It has to be very, very clear in your history of present illness, so that this was the loss, and whether it was progressive and non-progressive, or whether it improved subsequently. So you have to make it very clear so that examiner doesn't have to ask anything regarding this history. See, if examiner has to prompt you for answer, you won't get adequate credit. If you tell things on your own, you will get more credit. So don't let the examiner ask many questions. Your history should be very clear. History of present illness should highlight the chief complaints adequately. So like this patient had loss of vision, and then followed by pain after few months. So then you have to elaborate pain. Initially it was painless, and then it became painful since last 1 month, and then severity of pain, it was moderate to severe, associated with further decrease in vision. So this is very important. If you miss this, then examiner won't be satisfied. And then this pain was associated with nausea sometimes, and there was radiation of pain also. So again, you have to highlight these things in the history only. And then negative histories are also important. And then past history and history of surgeries and treatment or laser, whatever has been done, you have to highlight. So this patient had CRVO, in fact, and then it was kept under observation, and subsequently patient go on to have NVI and NVG, and for which the PRP and intravitreal injection of Avastin was given, and it was followed by trabeculectomy with ologen implant. So then patient reported to our institute, and this is personal history, systemic history. Patient was hypertensive since 5 years, so this point has to be highlighted, because hypertensive patients are likely to have vascular occlusions. So this is general physical examination, nothing significant. Coming to ocular examination. So uncorrected visual acuity, pinhole visual acuity, and best corrected visual acuity, it has to be written and told. Then in this patient, intraocular pressure is 48 millimeter mercury. Then you have to tell the type of tonometer, like this is with Goldman applanation tonometer. And then you have to tell number of medication patient is receiving. So without any medication or with medication. If with medication, how many medications and how frequently. Then you have to describe conjunctiva. This patient was having circumciliary conjunctival congestion. And since this patient had undergone trabeculectomy, so you have to tell about the bleb. If you don't tell about the bleb, then you will get negative marks. So you have to tell about the bleb, grading of bleb on your own. So since pressure is very high, so this trabeculectomy has failed, in fact. So this patient had finding on iris, there was NVI and ectropion UVA. Remember, if a patient has NVI and you mention about ectropion UVA, so examiner won't be asking you about gonioscopy. Why? The NVI doesn't occur in isolation. In fact, it's a membrane. It's a sheet covering entire iris going towards the angle. So initially, as Dr. Vinay Gupta showed the NVA, neovascularization of angle. So NVA starts from the pupillary border, goes and progresses towards the angle. So once in initial stages, angle can be open, but most of our patients come late, and once this membrane contracts, what it will do? It will contract in total, and it will lead to closure of angle as well as ectropion uvea. So presence of ectropion UV mean that patient has already had angle closure. So sometimes because of corneal edema, if you are not able to do gonioscopy, so presence of ectropion uvea, you can confidently say that it's closed stage of neovascular glaucoma. So gonioscopy has to be highlighted in this patient. And then fundus finding, you have to tell about, since patient is having NVG, so then glaucomatous optic disc changes have to be told, and then you have to tell any other finding like the PRP marks in this patient. Since this patient has undergone PRP, so laser marks will be there, so you have to tell that laser marks are there from this area to this area. So then case summary, you have to make case summary. Patient had this problem, was diagnosed with this problem, this diagnosis was made, and then these things were done in right sequence. And then you make final provisional diagnosis. So in this patient, it was NVG post-ischemic CRVO. So coming to differential diagnosis. So what are the tips for differential diagnosis? So recognize a collection of signs, recall basic pathophysiology, restate in terms of disease, reconnect with initial complaints, and then frame the probability. So how does a patient of NVG present? Patient comes in acute stage, acute red eye, painful red eye. So what will be the differential diagnosis in a patient with painful red eye? So all problems having acute rise in pressure. So whether it's your lens-induced glaucomas, your acute angle closure, uveitic glaucoma, or in pseudo-exfoliation also. Because in our country, we have angle closure is very common. So in pseudo-exfoliation also, more than 10% of patients of pseudo-exfoliation, they are likely to have closed angles. So they can also come with acute rise in pressure. So if you tell differential diagnosis, what happens? Your senior resident tells or junior faculty tells that this is the diagnosis. So the moment you are told the diagnosis, you get derailed and you never come back on the track. So never ever focus on the diagnosis. Just make a working diagnosis. It may be right, it may be wrong. But if you are able to make right differential diagnosis, the examiner will be satisfied. So then management, relevant investigations, and treatment options. You have to know medical and surgical options and support every option. So like a patient of NVG, you can do trabeculectomy with MMC, support with evidence. You can do implant, AGV or ADI, support with evidence. So these are the area tested during a long case presentation, and the deficiencies seen in most of the candidates. In history taking, physical examination, and laboratory information, we are inadequate with history and clinical examination. So like choice of therapy or alternative, you have to justify the plan and alternative strategies. In this, we lack in consideration of other options, choosing an unsafe plan of technique, or lack of awareness of potential problems chosen. Is my time over, sir? Okay, so I am finishing. So ability to deal with emergencies, this is another area. The failure to consider all available data, interpret new findings, and initiate a timely response and plan of management. This is the area where we are deficient. And communication skills, they are very, very important. If you are confident, you communicate well, you will get additional marks. So these things will be dealt in by next speakers. So at the end of long case, don't grimace, weep, or look desperate. So you don't know whether you have performed well or not. So don't conclude. Let the examiner conclude. They have come here to make decision or conclusion. You are nobody to judge yourself, okay? So don't hang around the examiner. So just leave when you finish the long case. And take home message from my presentation is tailor your revision style to the exam style. Practice question and answer with your seniors and batchmates. And remember, the examiner has to come to help you. He wants you to do well. So meet them halfway. Good luck, all of you. Thank you.
Thank you, Professor Suresh, for excellent, in-depth assessment and advice for preparing for exams and studies. Thank you very much. May I invite myself now?
Professor J.K.S. Pariyar, Major General Professor J.K.S. Pariyar would be speaking now. You see, he has got
For
green shirt.
dais and chair, one need not to wait for invitation. It will never come. And I think Dr. Santosh is not here. It is
He has
good
just
that
gone.
what I am talking, he should not listen. That when I started my residency way back in 1980, we didn't had a lovely smartphone, computers, and internet. Nothing was there. And library had a beautiful recent advances which was purchased 10 years ago. We didn't had a stalwart teachers like Professor Chauhan, Bhavna, he's my younger colleague, and though she's a professor in AIMS, Professor Kamaljeet. I gone through the total 7 speakers, if you collect their all expertise and experience of teaching, it amounts to be 175 years. If there is some kind of a overlapping, still you have in one session more than 100 years of experience from all different parts of the country. So that is the beauty of this program. And that is why I said that Santosh should not listen, that he has given us this platform to go ahead with that. Now, 2 previous speakers have made my talk very simplified, and I am a very lazy person, won't like to talk much. My next 3 speakers, they are going to talk what I am talking, so I will skip so many slides so that there is a less overlapping. Yes, when you are going for the residency 3 years, whether it is a MS or for DNB or the 2 years of the diploma, after all you are undergoing the ophthalmic residency, and tips given by Professor Chauhan is valid for each and every student, whether he belongs to any discipline and stream. That's very, very important. So I consider very fortunate to talk on the DNB examinations. And as we all know that there are the 4 papers, what I want to stress is here, stress on basic sciences. In clinical medicine, basic sciences are clinically oriented, and theory is clinically oriented, practical exam is clinically oriented. So we did not to go into the too much details of the theoretical aspects of it, but to confine to the basic sciences applied with the clinical applications. Then surgical and medical ophthalmology, recent advances. Most important is there is no negative marking, so attempt all questions, attempt all parts of questions, don't attempt which is not asked for. It's very, very important. Each and every part will have some kind of a marking. If the question carries 10 marks, then there will be 3 parts, 2, 4, 4, 2, 5, 3, something like that. So if you have not attempted one particular component of the question, you will not be marked at all. And I reveal one secret, that almost there will be 10 questions in one paper. So if you have 60 copies, I have to check there are the 600 questions, and 600 questions I am given 9 hours. For that I have to go for natural call, breakfast, tea and everything. So practically for one question I have less than a minute. So I'll look like a question like this to this and this. So I have to decide what exactly is coming there. It's very, very important. Be precise and to the point. I always give the definition when you are talking about the refraction, that incident, parallel, light rays at accommodation at rest. I am going to catch only these 3 words. Rest all, whatever you have written is of no meaning. So it's very, very important. Be to the point and do all questions. If you have 3 hours time, keep it yourself for 2.5 hours so that you have enough time to check overlapping and think about and finish in time. Because if you miss any question, you will not be assessed on that question. So it's very, very important. Yes, now second part which comes is the OSCE. OSCE earlier used to be considered as a good tool to get the examinations through. I have seen the students, those who have not done well in the clinical part, but they, by virtue of OSCE, they were making it. Now it is different. Thanks to Kirti, I think she has come. And Ritu, those made a very difficult OSCE for all of us. I myself find it difficult to go ahead with this. So you have to practice regularly on the OSCE is very, very important. Professor Ritu Arora has shown yesterday good slides, so I am not taking much on the part how it is being done, but it is a universal phenomena all over the world in the assessment in the medical and allied disciplines to assess a clinical assessments. So each station will have 5 marks for 4-minute durations, 100. Total goes for their 2 clinical case examinations of 50 marks each, goes 100 marks, one round has already been covered of 40 marks and Viva voce stations of 15 marks each per Viva station. So it's very, very important that you follow the stream and try to catch each and every component because the marking is divided accordingly. Out of 300, you should get around, I said like the big politicians say, "Ab ki baar 200 par." So you should also say, "Ab ki baar 200 par." So if you don't get 200, at least you will get 175. Keep a high target. If you keep a target to reach up to the Greater Noida, you will not reach even this station here because of traffic jam. But if you keep a target to reach up to the moon, at least you are somewhere in the US also. It's very, very important. Keep a target high, keep yourself confident on it. So it is a objective structured clinical examinations. As I mentioned, it is all over the world now standardized scoring sheet. And take time with the OSCE. Now I am fully convinced that we should stress more on the OSCE because it is the time for all of you. You are going for the fellowship exams. Again, these things will be more focused there. ICO exams, any international exams, it is all based on the OSCE. So think about OSCE, read about OSCE and do well. Prepare yourself. Do multiple sessions on the OSCE patterns. Now, what is exactly is there? There is a set of the relevant questions as discussed by Professor Ritu yesterday. Further investigations, differential diagnosis, management, complication, recent advances and applied aspects, these all will be clubbed in one chain. So it's so important to follow these. And there will be a student instructions for the patient's script and examiner's checklist. So this way you go. If you know your enemy, not the enemy, the rivalry, the examiner and his weapons, which is always taught to us in the military that if you desire to win a war, you should know the weakness of your enemies and prepare yourself to fight against it. And practice sessions, the training. If you कहते हैं पसीना अगर ट्रेनिंग में बहाया है तो खून नहीं बहेगा. Same way here. So you need more practice sessions on, and the another most important, the communication skill. Professor Suresh has also mentioned, Dr. Chauhan has also mentioned. So communication skill is how you are taking the history-taking counseling and presenting yourself. I don't play golf, otherwise I would have hit the ball here, whether in the open mouth here. And this type of, at least when you are going, when you are appearing in the practical examinations, your turnout is equally important. So that is why I thought it is a go green going. So as you see, I am already green. The complete green result. Your apron should be well clean and proper. That is equally important. And your conduct, as mentioned by Professor Suresh, should be mature enough because you are going to be the big surgeon in the future. Ward rounds we have already covered. Viva voce we have done just an hour before. So points to remember, time management. I have 8 minutes so I can put so much boring points now. Points to remember, time management. Now I confess, now these few slides I have taken from my student who took little time to pass in the DNB exam. Most of the students, -2, in last 25 years, they made it in the first attempt. 2, they took some time because they followed my last word, which I'm going to cover. So I asked her, I said, give me now you are through, tell me what was your problems and how did you manage it? So she had given me these points to remember. Thanks to my student that she taught me now. Time management is very important. Practice for OSCE in given time frame. Read all questions carefully and answer them all within the time given. I have mentioned about it. And like if there are the different sections, attempt all those, check for the question number on the screen and your answer sheets. No negative marking, so you can definitely play like a helicopter stroke of Dhoni. You can put ball here and there, you are not losing mark. very, very important. And the most is keep your nerve cool and give your best. And don't pick up the hints. As it has happened yesterday also, the hint may go sometime in a tangential directions. And Professor Chauhan has rightly mentioned that you can't appear in the final exam just after 3 years doing nothing, watching YouTube and so. So you have to have the multiple sessions of the rehearsals. And most of the colleges, they are doing it for DNB now, internal appraisals and FAT and all this is basically with the kept with this international patient that at least before appearing the final exams, whether it's theory or practical, the candidate is well exposed and rehearsed and prepared and become confident. When you are talking to the examiner or this, you must be little, now I won't say submissive, but mature enough not to be arrogant. But all big singers, the Shastri Sangeet, it never comes from the lips, it comes from the throat. So when you are talking, you should be confident enough and talk from the throat rather from the lip. Otherwise, there are the two common syndromes in the examinations. The both are together, constipation and diarrhea. Both are there. There is a diarrhea of the expression, the thought, and constipation of the expressions. Sorry for this odd word here, but it happens. I also had undergone the same problem. So nothing new in it. But we have to come out of it. So start talking with confidence, and mirror practice is very important. If you don't have anybody, you consider any electric pole as an examiner who doesn't know anything, he can't, and there is no electric wire is there. So there is no, and you keep on talking on it. So you learn how to speak and face the public forum. That's very, very important. And I think chair will bear with me. If you ask any poet to give the ophthalmology, he will definitely add on something. Shikhar par lehrati dhwaja sabne dekhi hai. A person who has already gone and reached up to the top, everybody sees, oh, ये तो ऐश कर रहा है. उन आँखों की चमक सबने देखी है, पर चलते हुए राहगीर की पेशानी पर पसीना, हाथ और पैरों में उठे छाले किसने देखे हैं. You have to struggle, work hard. मंजिल को छूना हो गर राहगीर तो चलना सीखो, मत करो इंतजार वक्त का और साहिल का, हौसले हो बुलंद जज्बात के साथ हो, जुनून और फितरत में हो सिर्फ और सिर्फ जीतने की कशिश, जुड़ी हो जिसमें कड़ी मशक्क़त तो फिर फिक्र क्यों, हर हाल हर फाल में सिर्फ जीत ही जीत है. और ये मैंने आपके लिए परसों ये सैटरडे रात को ये लिखी थी, स्पेशली डेडिकेटेड टू ऑल माई beloved DNB students and other students. I enjoy when I am with them, I learn a lot, and I become 40 years younger when I am with them. We go back in our residency. So that is their contribution in our life. Revision, repeating and revision is the ultimate key towards not to repeat the examination. And this is word about it. I put myself here on the second line. A most wise person cannot answer a question raised by a most ignorant person. So if you are not able to answer my questions, don't mind it. It is very much there to, you have a better, since I have 3.5 minutes, I take 1 minute and 2.5 minutes I give to the next speaker in addition. If I am standing before all of you here, with this respect, I owe to my teachers, this is one thing. I still talk to Professor Nata, who is 93-year-old, and at least twice or thrice in a year we do talk. And I reveal my success story during residency days. So you will be very proud to see that what you are getting is much, much higher than what I did. I did only 3 intracapsular cataract surgeries with 100% success in the first case. Everything was out. It was the expulsive hemorrhage. Second, it was only the lens which came out. And in third, lens and there was a vitreous problem. So if with those 3, and this US Tiwari was my senior, 1 year senior to me, he was holding my hand. So I still remember, I said, you gave me these 3 surgeries. From that, if I have reached up to here, most ordinary students never like to be part of, like Professor Chauhan said, ophthalmology की बात करो तो ophthalmology. I was never interested. What is this? No, क्या है? Camp में करो और hospital में करो एक ही बात. But now I cannot imagine myself without ophthalmology. My first love is ophthalmology, second love is army, and third love is my wife. Thank you very much.
सर आपने गर्लफ्रेंड के लिए नहीं बताया. So the next speaker is Dr. Bhavna Sharma. You are speaking? Okay. So Professor Kirti Singh, as you know, she's a wonderful speaker, a great poet, professor at Maulana Azad Medical College. We have so many things almost the same. Keep on talking about poetry. अभी कह रही थी मैडम कि पोइट्री नहीं सुनाई तो सर ने तुरंत जो है परिहार साहब ने सुनाई. तो शी इज़ अ वेरी गुड पोएट ऑल्सो. तो हम इनके लिए यही कहने चाहते हैं कि काम में मशगूल रहे खुश ना हुआ कर. काम में मशगूल रहे खुश ना हुआ कर. दुनिया इतनी वीरान नहीं. तो आपको केवल काम नहीं करना है, आप लोगों के लिए है. ऑल योर रेजिडेंट्स 8 से 8 काम करो और बाकी मैडम जो समझाएं वो आप समझो. मैडम प्लीज़.
Thank you. Thank you to Dr. Santosh and his team of CFS for having me here in iFocus. It's a pleasure. Can I have the slides, please? So what I'm going to talk to you is about OSCE. Sorry? Yeah. So do you know where OSCE came from? I am a lot of history things because history teaches us not to repeat mistakes. That's why we must know history. Not for any other reasons कि वही गलतियाँ जो पहले हुई हैं historically वो दोबारा नहीं करें. So the history is that there is an OSCE station. It came from Dundee, Scotland, and UK was the first country to start OSCE, and now most worldwide places you have OSCE because it's easier, it's structured, it reduces the stress on examiners, it doesn't increase the stress on students because it is very structured, and you have same time for each. So actually, at our time, an examiner would start asking questions half an hour, 40 minutes, and they would not stop. That will not happen. So let's come to glaucoma OSCE. I've made some pictures about the OSCE. What happens in the OSCE station is you are giving the same time and you have this picture and you have a clinical scenario or a picture and you have structured questions. So I would want some help in OSCE. Can I get the help? In other words, I want some volunteers. So, okay, so please, the lady, I may forget the names, so just bear with me. So this is the picture. This is the OSCE questions. A 55-year-old female presented with sudden vision loss and pain in the right eye. You know what OD and OS is? Oculus dextrus and oculus sinister. What is the probable diagnosis? 1 mark. What is the type of conjunctival congestion? 1 mark. Name 3 investigations you would do in the OPD. What is the management protocol to be followed? So this will be the way the OSCE sheet would be. And you will be given a sheet next to it, plain sheet, which you will pick up, and you will write 1, 2, 3, 4 answers. So anybody wants? So what is the probable diagnosis?
It can be an angle closure glaucoma.
It is?
There's circumciliary
Acute angle
congestion.
closure
Acute
glaucoma.
angle closure.
Okay.
There's circumciliary congestion and investigations.
It's called as circumcorneal.
corneal.
It's not called as circumciliary. It's circumcorneal or ciliary. What else?
Ciliary congestion.
3 investigations you will do in the OPD.
Ma'am, once the pressures are controlled, I would like to do a gonioscopy.
How would you pressure? Okay. First of
And-
all?
I have to measure the IOP first.
Okay.
So I can, but there seems to be corneal edema,
Yes,
ma'am,
there
and
is.
microcystic edema.
Right.
So,
So which
IOP
tonometer?
by NCT can be done?
Error.
No.
Okay.
Or a
Non-contact would not be very great, but Perkins, if you have, might work. Eye care might work. Mackey-Mark, we don't have anymore, but some examiners with the gray hair like mine would want to hear Mackey-Mark from you. But we don't have Mackey-Mark anywhere. Okay, so tonopen. Digital still works. So please take your fingers very seriously. They're going to be there with you for life. No tonometer will be there with you for life, but your fingers will be there. Train them. They'll be a good assistants. Visual acuity क्यों भूल गए? Visual
visual
acuity.
acuity, yes,
Van
ma'am.
Herrick's,
And
gonioscopy,
gonioscopy
and
fundus
fundus
disc.
evaluation. Obviously, the last 2 you would want to do after the IOPs, the corneal
Control.
edema goes down. But if you say 1 or 2, any of these, you'll get the marks.
First, we have to control the acute rise of IOP. So we can give systemic IOP lowering agents like mannitol 20%, glycerol 50%.
Now this is an OSCE, this is not a Viva question, but in the Viva, if you're asked, you will not give the beta blockers or anything until you've controlled the IOP. You know that why? Because there'll be no
Takes time.
penetration. Okay. And what I've written in red, if you answer this in the this or in the Viva, you'll get 100%. Actually, from me at least you would. Why?
Other eye gonioscopy.
Because
should
one
be
eye
done.
has gone into attack. Okay. Please remember, please remember, एक मरीज की one patient has two eyes. Thankfully, look at the other eye always. Whenever you give an exam, whenever you see a patient, always focus on the other eye. Okay. Also, so you can just do a Van Herrick's. If it's a short case, do the Van Herrick's and see what it is. Do the tonometry. And you will say, fellow, I would like to do the gonioscopy if there's no time, or this is both for Viva point of view and OSCE. So good. Second one. Next person can speak. The lady in green. What is this? These are the questions. 60-year-old female presented with sudden vision loss and pain in the right eye. Name two signs seen in the left eye of the same patient. This was the right eye of the patient and the left eye. Okay. Two signs in the left eye of the same patient. Name two tests you would like to perform in this eye. How would you manage this left eye?
मैम ट्रोमैटिक मिड्रियासिस है
Okay. Right, left eye क्या थी इस patient की? ये क्या था?
मैम एक्यूट एंगल
Now you're talking of two diagnoses. एक में trauma और एक में glaucoma. Unlikely, no?
मैम
So I said no. Same patient. Name the signs of the same. So there are two OSCEs in rows. Very rarely you'll get such an OSCE. I just made it like that just to make it fixed dilated pupil.
यस
Iris atrophy.
ग्लूकोमा मैम क्रोनिक एंगल क्लोजर ग्लूकोमा
Sphincter. There is no such word as chronic angle closure. What is the ISGO classification of glaucoma now, which is accepted worldwide? PSCS, PSC, PSCG. The terminology of chronic or creeping angle is old, not used. So, and you have this glaucoma flecken. Okay? This will also be a spotter in some exams that you should know what glaucoma flecken is like. Name two tests you would perform in the left eye. Similar. If you want to talk about the Eagle study and the further studies of the Beijing study, you will talk about the lens fault. You may want to do that because this cataract, if it is very high lens fault, you may go for cataract surgery. But laser PI trial with AGM, depending on the glaucoma severity, that's the structured approach to a PSC. Now this stage is, what is the stage of the patient? PSCS, PSC or PSCG?
मैम
Why do you say that? Why do you say PSCG? Iris signs are there, lens signs are there. PSCG means you have to have the fundus or the disc signs, which you don't know about. So this may be PSCG, but from anterior point of view, it is just PSC. Okay? Thank you. Next, please. Dr. Perihar's favorite thing. What is this picture showing you? 60-year-old male has poor vision both eyes. He has had multiple surgeries done in the past. What surgeries are visible in the right eye? Mike ke paas aaja. Other people just be on the mic. It's fun. I mean, this is actually just what surgeries are visible?
I can see a stent in the
What is it called as? It's not called a stent in glaucoma. It's called as a GDD, glaucoma drainage device. Can it be an ADI? Can it be an AGV? Can it be a Barwilt? How would you know? Can you know just from this picture?
No, probably the size. If I could see the bleb and the size of
okay.
it, then
You can see
a
some
large
part of the bleb. All right. So you'll just say a GDD. Okay. What else is visible? What else is visible? I said
I
what?
can see an IOL also.
So it's a pseudophakic eye or an aphakic eye? Usually pseudophakic aphakia you would not have in such nowadays. So pseudophakia, what else? What is this?
PI, peripheral iridotomy is
Okay,
also be done.
so probably it's a failed trap.
Yeah,
You would not do a PI otherwise, no, here. And because the normal site for a PI would be here. Supranasal invariably, and this is a surgical PI. Nowadays, some centers still do a surgical PI, but most of us do a laser PI. So why would you do a PI? You would do the This is a failed trap which has gone into a, we had to have a tube shunt done. Which study talked about failed traps and then tube shunt? Which famous
TVT
study?
tube
TVT
versus.
What are the other
traffic.
studies? Okay, we'll come to the next question. Oh, sorry. What surgical complications are visible? Where is the tube? It's very front. Pupil?
Is distorted or irregular.
Okay, and the trabeculectomy, obviously, we are assuming it's scarred because why would somebody else put a tube otherwise? But this third part, you may not do, but tube migration, very visible, it's front. Otherwise, the tube should be till here, okay? Pupil is irregular, okay? What surgical maneuver would minimize these complications? If you picked it up, you would say trimming of the tube, beveled entry, anchoring the tube. You have the various techniques of tube entry. So this is a little higher order question. These would be the basic ones. Okay, that is why the marking is 2, 2, and this is 1 mark. So if you've scored there, there's no way you can fail the OSCE.
Maybe making fenestrations on the tube would also prevent.
For valve tubes, no fenestration needed. For non-valve, you would need. So how do you know this is non-valve? We don't know, no?
Okay.
So we are assuming. So this is usually in India, unless it's ADI, it's usually AGV. So if you have to err on this side, obviously you want to see the whole bleb, but you would say it's one of the valved ones. Okay? Thank you. Next. Somebody else can volunteer? Come please, Bache. Yeah. Okay, so this is another surgery. This is intra-op picture. I haven't completed the surgery in this. Seen the surgery? Okay. So which surgery is being performed? Simple.
PKP. PKP is done.
PK is being performed. Really? See the scar marks? It's an old PK. Tube shunt is being performed. Why would you have perform a PK with this? Or if you're saying combined surgery, look at the scarring. It's an old PK.
Yes.
It's not a fresh one, okay? What technique is being used to place the implant?
Suprachoroidal.
No, technique. This is a GDD tube, glaucoma tube shunt being placed by which technique? Anybody? Tunnel technique. Okay, you're using the tunnel, otherwise you have closure by the pericardium. Outside here you have scleral patch grafts, corneal patch grafts. Okay, what is the probable preoperative diagnosis? It's a very simple diagnosis here.
Post-PK glaucoma.
Post-PK glaucoma. So, okay, thank you. Next person, come from this side. Fatafat aaja. Okay, so this is the picture. What surgical complication is depicted in this?
Madam, ma'am, first year I will try.
No problem, no problem.
Ma'am, looks like tube migration.
One is tube migration. What else?
It's trying to come out.
It's trying to come out, yes. Tube erosion or tube migration. Right? So that's called as tube erosion. How can this be managed? Anybody wants to help this first year for hours? That good? You are attempting? Anybody? Patch graft, cutting the tip of the tube, repositioning and trimming the tube. Patch graft with re-anchoring the tube. Okay, very often you'll have this tube erosion. That's one of the common complications of tube. Which RCT? We've discussed this already. TVT or ABC studies. So if in the Viva any tube exams are asked, so ABC or TVT would be mostly quoted at you. Okay, thank you. This is a field OSCE, visual perimetry. Name the perimetric test done. What are the findings in right eye and left eye? What further perimetric tests should be ordered before deciding management? So tell me when to stop. Radhika, just tell me when to stop because I just thought it will be interactive. Okay, so now the field has been cut off from there, so you can't make out, but Humphrey's theta 2 and right eye is showing an advanced damage and left eye is showing a double Arkwitz scotoma. First of all, reliability indices would be there. Here, you don't have all the reliability indices. I had to cut off the superior part. So here you would say, I don't know, the reliability total indices are not available. But if it's a reliable field, you need to check the reliability indices and what other imaging test would confirm this finding, which is very obvious. RNFL. RNFL में OCT में they'll ask you the questions on RNFL. CP RNFL is circumpapillary RNFL layer or macular GCC. Macular GCC is the new buzzword. Most of the new OCT machines have that in advanced forms, and you talk about the floor effect and when to do a macular GCC and when to do an RFL. Okay? A 10-year-old boy, I'm sorry, a 10-year-old boy with this finding has presented with itchy eyes and vision loss. Refraction findings reveal minus 2.5 diopters myopia with a BCVA of 624. He has been using anti-itch eye drops for the last 5 years. What is the probable diagnosis? Allergic conjunctivitis. Okay. Now the thing is VKC, and he's been the clue is that the vision is BCVA 624. Why would the vision be less in allergic conjunctivitis? So it is either steroid-induced glaucoma, it also could be K-conus. Okay, both are linked with VKC. What ocular association with this disease can cause visual loss? Again, the same things: shield ulcer, conus, iatrogenic glaucoma, even cataract. So VKC question can be very often asked in the theory as well as in the viva. What are the treatment options? You should know all the latest treatment options like, anyone? Safer anti-inflammatory like tacrolimus, cyclosporin, loteprednisolone, and withdraw the steroids, wait for 2 to 4 weeks. Steroid responsiveness usually goes away in 4 weeks' time. And in the meantime, use anti-glaucoma medications. If it doesn't respond, which again it doesn't very often, you may need a surgical intervention. Would you operate on this eye like this? If you have such deranged ocular surface, your trab would fail. Okay, so if this picture is shown to you like you had this viva, grand viva, suppose the picture is showing to you like that, you would say, no, I would want the eye to be quiescent before I operate because trabs would fail. Okay, this is not my picture, the others were mine. So I have the time's up. So what surgical complications are depicted? Uchi bolo. Blebitis. What is this? Blue filter. What is this test called? So this is Siedel's positive. Avascular thin bleb, leaking bleb, Siedel's sign positive. What is bleb sweating will be the next question asked. What is mitomycin C complication would be asked next. Avascular bleb, all those aspects. What surgical precautions could prevent these complications? They'll come to the trabeculectomy complications. What surgical precautions? Anybody? Usually a complication because of mitomycin. You can't do without mitomycin, and you have all these problems with mitomycin. Safe application of the Moorfields technique. Conjunctival buttonholing has to be prevented. Releasable sutures and bleb titration. Management options of Siedel's positive. What is Siedel's scotoma and what is Siedel's test? Siedel test is this. What is Siedel's scotoma? The scotoma in the paracentral areas with an early arcuate. I think that should be the last one. Bleb excision. This type of bleb can't survive, so bleb excision and resurfacing by conjunctival flap, autograft or amniotic membrane. Okay, I think this is the last one. Number 8. What is this? Anyone? Harpstry. Large cornea, Harpstry. Probable diagnosis, 2 differential diagnosis. PCG, buphthalmus, megalocornea, birth trauma. How do you differentiate birth trauma from megalocornea? Size of the cornea. See, the cornea is large. Okay? So it should be vertical. We very rarely see birth trauma now because of good delivery techniques. And 4 surgical options for this disease. Trabeculectomy, trab and trab. Goniotomy, IMCT, illuminated fiber optic catheter, assist trabeculectomy, or ab externo, or the Schlemm's canal surgery. I think I'll stop here. Rolika, is that okay? Yes. Yeah, because otherwise it will extend. So thank you so much. And I leave these OSCEs with you. You can have a look at them. There are around 25 of them. So this paper is not leaked, but this is how the OSCEs come about. Okay, and OSCEs are pretty. It's not difficult to do that, but as we know, for any exam, you need a thorough preparation and revision. Thank you very much.
Thanks, Professor Kirti, for wonderful presentation, and we are also enriched by your presentations. It's a great, rich treasure for all of us. Thanks a lot. Now, may I request Professor Bhavna? Yeah, please. She is head of the department at AIMS Bhopal.
And just a little note to all of you, the handouts that you have will be updated. Those are the handouts from the previous session, previous years. That's useful for you. The recent ones will be added to those. Don't worry about it. Okay?
So, it's a pleasure being here today. I thank the CFS teams, Honavar sir, Rolika, Dr. Rashmin, and everybody who's involved in organizing this fabulous event. And I would be taking you through this presentation on how to prepare for theory exams. And I think I would be in best position here to take this lecture for you, being the Dean examination also. And believe me that I would divulge some secrets, some confidentiality tips to make you, gather more marks in theory exams. So what do you understand by theory? By theory, it is a set of principles, documentary evidence that provides an explanation of working of a concept or basis of practical happenings or connections between various principles in a model or working together. So this is the definition which is being told, which is being, we gather through the MET or the education workshop. But I am as confused as you are looking into this definition. So I will simplify this for you. It is not that, difficult here. It is as simple as this picture, that the theory is the script which will take you through a beautiful and a meaningful outcome at the completion of your learning tenure. And just like the script of a movie is, if it is a well-written script, you will have a well-written outcome. The training part will be complete. The training, the learning schedule, the training, everything would be complete should you have the theory knowledge perfect, okay? So that is the importance or basis of having a good theoretical knowledge in your learning curriculum. So, as I said that the first definition was so confusing, let us see this most simplified definition, that it is just to put your thoughts into words in a very meaningful form to evolve through a process of learning and its execution, right? So what is the need for theory exam? Now you can see this medical humor, and you can see that had this gentleman had a theory knowledge, he would have had given a more objective and logical treatment to this patient. So it is the most important or very significant aspect of medical science. And also it is, to assess the cognitive domain of a student, which is the foundation of, other two domains, that is the affective and the psychomotor domain. So if the foundation is strong, the cognitive domain is strong, your skill, your psychomotor aspects would be as strong as your theory is. So believe me, you need to have a good theoretical knowledge to master these two domains as well. So this is Bloom's taxonomic pyramid, and it tells you the process of evolution or learning through your in your training period. So while gathering the knowledge or the theoretical knowledge, its comprehension, you know the applicability. You also analyze it and also synthesize more information out of this. At the end of the learning tenure, you will know that what is the deficit or what is the gap or what is the lacuna in that to supplement your knowledge. So you would be in a position to evaluate your knowledge as well. So that is the stage from knows to shows how. Right? So this is the importance of theory, and it provides the actual happening, the knowledge about the actual happenings. So by this, up to here, you are well versed that it is nothing about mugging up. So stop mugging. You want to go to, you want to read the theory to have the concept of that particular topic, right? So you can design your study plan yourself. I'm not going to go into the detail, but maybe this can be a helpful slide for you, that how do you want to study, when, where, what do you want to study, with whom, and why do you want to study? What is the purpose of you want to do a cornea fellowship, you want to go, take some, medical profession in the foreign countries or anything. So that way you develop your learning, and you study the modules, or you develop your aptitude according to it. So that is the study plan which you must structure at the beginning of your training. And from here I will take you through the actual theory preparation, that is what to study, how to prepare, and how to give the exams, right? So the first part is what to study. So what to study is that you have to study everything, keeping in mind that you want to aim for preparing all subtopics, whatever is asked in the exam, and divide the proportionate time depending on the, the weightage of marks in that, and also the length of the topic, or how extensive that topic is. And you must know, one thing I always stress is that you must know something of everything. It doesn't make a point that you master the retinal procedures or recent advances in complex retinal surgeries and you don't know about squint basics. So you must know the basics of squint as well as basics of retinal surgery. Then you have times you can prepare for the complex retinal procedures as well. Now, this is the secret which I would like to divulge here, that almost always the previous year question papers are repeated. I know this because whenever I send an invite to an examiner, what is enclosed in the invite is the invitation letter, the acceptance letter actually, the confidentiality or the disclosure form, and the third is the previous year question paper and the format. So the examiner doesn't have time to go to various resources, books, go to internet. He will look at the previous year question paper, see the format, and just change something on that papers and give you back the question paper. So always read the previous year question paper. They would definitely guide you to what kind of questions you are being asked, and you would be able to prepare them better. And you must also, by seeing these previous year question papers, you sort those topics in the descending order of their occurrence. That is the most commonly asked. You must prepare them more firmly. And also so that they constitute the must-know component. You must know something about them. Rest of the topics, of course, you can prepare, but these are the things which you must prepare for sure. And also, as I said, that you must devote proportionate days or time to, depending on how extensive the topic is or how lengthy that topic is. And sorting the question, always prepare your topic the subject-wise or subspecialty-wise, because NMC also mandates the same. So these are the subheadings in which specialty-wise you should prepare. And NMC also mandates the same, as I said earlier, that the paper 1 constitutes the basic sciences related to ophthalmology, refraction and optics. This is by and large same throughout India. The systemic diseases, clinical ophthalmology and recent advances respectively in paper 1 to 4. Your exam should be at the end of 36 months tenure. And theory exam weightage is 50% and practical is 50%. So you know that there are 4 question papers of 100 marks each, which will constitute 75% of theory and 25% of your internal assessment. So that is why the theory preparation should be adequate and should be done in these lines which I am telling you. So what is required for you to be knowing in this theory knowledge is that you should have the basic knowledge of that particular topic. You should be able to handle any case related to that independently, should be familiar with the epidemiology, with recent developments, and also should be able to answer any research question or any gap in any lacuna in that, and also should have some knowledge about the medico-legal aspect. So this is how you want to, taking the help of the previous slide, this is how you would like to prepare any topic, and this is the key to answering all questions, all topics in your theory exam. Like, start from epidemiology, the natural course and pathophysiology should be known to you. Symptoms and signs, many of the times they are overlapping between different conditions. Like most of the corneal conditions will have similar symptoms and signs. You read about ulcer, you would have almost similar for the dystrophies and for degenerations and and inflammatory conditions, like similar for the retinal pathologies. Management includes the investigations and treatment, and also the differential diagnosis, of course. You must know about the advances and recent advances and the sequelae and the complications. The resource material for this can be your textbooks. If there is any difficulty in answering any question, or there is any gap or a lacuna, you can refer to other reference textbooks, and recent review articles are very helpful. These are the important topics, as I said earlier in the previous slide, that the paper 1, 2, 3, 4 is constituted by this topic. These are much neglected topics that you must not leave, you must study them, and these topics, they are often asked in exam. This I am telling you by my knowledge of previous year question papers, which we receive and we are being, giving to last several years. Now, the second part, how to prepare for the theory exam. So this concept is an important concept, that is the Feynman method. That means you learn a particular topic. Of course, on these lines you prepare your topic. Then you take this lecture to your colleague, to your friend, or to a student, to a UG student, and after you have taken this topic or taken a lecture for this student, you would identify that where was the gap or lacuna in your teaching, what were you missing on. So you would introspect and you would read it again and prepare it more better, right? So this is a very effective method, and believe me, if you follow it, you would be able to understand the topic better, and also prepare for the theory exams, and also prepare for the Viva exams as well, because this is, once you have done this, you would also be fluent in the Viva. The group study is important, as I've said, and yes, of course, whenever you are not having any answer to any, subtopics, say the recent advances is not given in a particular, can't see the recent advances of keratoconus is not given. So try to find out from other resources, because that is an important area which would be asked in Viva as well as in theory. So never leave that, never leave any lacuna in your preparation if you have time. Of course, you must refer to other books, other resource materials for that. This is an important concept, that structure and analogy. I would like to give two simple examples, like astigmatism. What is the most simple analogy which comes to your mind is, a baseball-like figure that gives you, a look of a, what is this? Can somebody tell me? With the rule or against the rule astigmatism? Sorry? Against the rule astigmatism. So you must structure your own analogy. The dry eye disorder, it can be, compared to a arthritis patient where there's loss of fluid, the synovial, the two surfaces are rubbing against each other, there's ongoing inflammation, and that there's a vicious cycle. Dry eye disease is similar. So what would you treat? How would you treat? You would not go on giving him lubricating and lubrication and lubrication. You would give anti-inflammatory drops, just like you would give for the rheumatoid arthritis. Rheumatoid arthritis, you're giving steroids, you're giving anti-inflammatory. Same is for dry eye. You're giving steroids, you're giving anti-inflammatory, and supportive with the lubricating drops. Mnemonics. Mnemonics are very important. I'm giving you three examples, like cones for clinical signs of keratoconus, right? I can see this stuff is a mnemonic. I have not structured them. There's a book, there's reference which I have given you. This mnemonic book in ophthalmology is available. You can search in the net and you can take help from this. They're all taken from here. I would like to explain about the STUMPed. STUMPed is the causes of corneal opacity in pediatric age group. So what does it constitute? It constitutes of sclerocornea, trauma, ulcer, mucopolysaccharidosis, Peters anomaly, the CHED, and what is this D is dermoids. Okay. So this is how you can, write down your formulas or mnemonics to help you prepare better, okay? Now, something is very important but also very boring. What would you do? So again, I would refer to my earlier slide. Just read something of that topic. You can go back to revisit that topic at a later time when you are fresh, when you have given a break of another, say 1 week or 10 days, you would be more receptive towards that topic. So this is the technique of spaced repetition, which would be very effective for boring topics which you're not liking. Okay, and you can make color coded notes. I'll take 2 minutes more. Yes. So coming to the writing part. You have studied so well, you have written so well, you have filled up the paper completely, but the examiner checked your question paper in just 2 minutes. That was so unfair. I understand that is so unfair, but he cannot help it. He has to, check n number of papers. He is there for just 2 days. In that, he has to conduct the practical exam as well as theory. So he has to check the theory paper in 5 minutes maybe. So it is your duty to impress the examiner by whatever short you have written. So I would tell you the writing tips, or how can you impress the examiner. Don't let the examiner search through your paper. You give him, in a platter that, see, I have written this, you just give me exams, you just give me marks. Okay. So these are the strategies for good quality paper writing. Understand the question. Plan before writing. Do not jump straight onto writing, What you want to write, I would again refer to the previous slide where I told you about the epidemiology, risk, the differential diagnosis management and everything. And convey in an organized manner in the subheadings which I told you, right? And support with examples and evidences. 2 mistakes to be avoided are lengthy paper. Never write lengthy paper. You would do nothing but annoy the examiner. He would rush through the papers like this. He will just, give whatever marks comes to his mind, but sure, it is not in your interest. And So an impressive way to write is an immaculate presentation with a legible handwriting through scientific terminologies. Do not use colloquial language. Like for keratoconus, bulging very much. CRVO, I saw one paper, CRVO, hemorrhage everywhere. No, you have to quantify. You have to quantify whatever you are writing, as I was telling you in the Viva also, that whatever you are saying, whatever you are writing is in a scientific knowledge, in a quantified term, you have got a reference, okay? And supplement with tables, flow diagrams, and spacing, as I'll tell you in the coming slides. And can I take just 2 more minutes? I'll complete this. Well-distributed paragraphs, highlights and bolds are very important, adequate word management, and also time management. So this is an example of an answer, a short note on management of VKC. Towards the left side is a very studious student who has worked so much, worked so hard, and he's filled up this paper with this writing. But the examiner, as I said, doesn't have the time. So in place of this, he could have written these 2 simple flow diagrams, and he could have got all the 5 marks for this, right? So supplement with the diagrams, flow diagrams, and write minimum to impress the examiner. Use visuals. Visuals are very important, but don't make mistakes in visual, because visuals are very eye-catching. उसमें अगर आपने गलती करी तो वो examiner को फट से समझ में आ जाएगी. So always be careful while drawing, okay? तो वहाँ पे गलती नहीं होनी चाहिए. The flow diagrams, as I told you, that they are important, and diagrams are important. Do make diagrams and underline significant points. Like see how beautifully this student has written, made a diagram of pathological conditions in the pupillary pathways and underline them as well, right? So always highlight and bold your important points. And what if you don't know the answer? Okay, so again, remember that earlier slide where you can see the epidemiology, the natural course, the symptoms. You will remember something from these subtopics. Definitely, I'm sure that you will remember, because the topics are overlapping, as I told you. The cornea topics are overlapping. The clinical signs and symptoms would be same for most of the treatment also would be same by and large for many conditions. So never leave a question paper. You will lose all marks. Write something in that question paper. Supplement with diagram, right? These are the recommended reading which an MC has prescribed, and I have written down for you. I think Rolika will give you the handout of this. You can have it at a later date. And to summarize, as I said earlier, you must identify the high probability topics, follow questions in order, divide equal marks for proportionate marks for each question. Don't let examiner to struggle through your paper. Use diagrams and flowcharts. Use different color highlights and underline your intended topics which you want to convey. And and last slide, which is the most important slide. Take good care of yourself. There's nothing to stress. Eat well, sleep well, take proper rest, and we are there to support you. Never do any stress on anything. You have worked through your tenure over 3 years. If you spoil your theory, we are not there to judge you on your theory paper. You are judged on the last 3 years' performance. So do not stress on anything, okay? That is the most important. And thank you very much, and all the best for your theory exam. Thank you very much. This is my team at AIIMS Bhopal. And one more, this is my book on corneal emergencies. If you want, you can have a complimentary copy from Sun Pharma, which Sun Pharma representative who visits you. Thank you very much. Thank you.
Thank you, Professor Bhavna Sharma, for such a wonderful presentations. Really, it speaks volumes on your experience and the way you have dealt with the subject and given guidance and directions to the students and the future teachers. Thank you very much. May I request Professor K.J. Singh now?
We have already done the practical of what I will be speaking. The practical examination that we were doing in the afternoon, that we have already discussed how do you give your practical examination. I'll give you some clue. पहली तो बात ये है कि आप अपने सीनियर रेजिडेंट को अपना गुड फ्रेंड बनाइए, because when you go to the examination hall in the practical examination, you will find your senior sitting there. They are the greatest help. और जिस दिन एग्ज़ाम हो उस दिन you reach there a little earlier. You will get the clue to the patients who are sitting there, who will be given to you during examination. So usually the examiners, they come to pass you. किसी भी तरह से आप पास हो जाओ और निकल जाओ और जो इंटरनल होते हैं उनका काम ये होता है दैट somehow this boy should go now. Already we have so many candidates there. There are many who don't like to go. They don't leave the department. So they learn a lot, but at that same time, many a time they become problem for us. So most of the time the examiners want that you go. In practical examination, you have a long case, short case, then this practical that we had done. And in long case and short case and fundus cases. These are the cases which will tell you that the examiner will judge you. Okay? If you have done well in long case, you see your examination is almost over. Okay? So in long case, what you have to do? You have to take a proper history. Ab the history taking is a problem. In our patients, in our setup, in a government setup, in our part in Allahabad, the patient will come and he will not tell. There was a patient who came to me in my examination. I asked him, what is your problem? तो बोली कि अगर हमें प्रॉब्लम आई होती तो हम तुम्हारे पास आए काहे होई. तो you have to find out, take a proper history. Diminution of vision है, कब से diminution of vision है? It may be from years or it may be a recent onset. It may be sudden diminution of vision, painless loss of vision, painful loss of vision. So you have to mug these things, the causes of sudden diminution of vision. Many a times we ask sudden diminution of vision, the boy does not answer all the answers that the causes that have to be given. तो अब पेनफुल है तो उसमें पेनलेस में बताना शुरू कर देंगे. अगर आपको याद नहीं है तो मान लीजिए पेनफुल ब्लाइंडनेस की कॉजेज पूछे तो आप ऑप्टिक न्यूराइटिस की जगह रेटिनल डिटैचमेंट बताना शुरू करते. So you have to remember all these causes. Deep anterior chamber, 1 or 2 causes the PG will tell, and remaining you will forget. In the examination you are very tense. So 1-2 causes बता दिया, uveitis भूल जाएगा, posterior dislocation of lens भूल जाएगा, aphakia भूल जाएगा. So what you keep on seeing daily, that is what the examiner wants to know from you. Whether you have worked in the department properly or not. And when you are sitting in the OPD or you are going into the special clinics, please write the details. Bed head ticket में आप लोग लिखते हो, but these days I find that they would write diminution of vision, cataract, diagnosis, and that's over. So you have to, supposing a patient comes with a headache, then you have to know whether it is because of migraine or because of sinusitis or because of intracranial headache, and there are differences in all kinds of headache. So that is a big problem. And many a times you get a patient of vitreous hemorrhage, and when somebody says that, have you done PL and PR, you forget, because you have got a B scan in your hand, but you don't have the regular habit of doing PL and PR. And many a times we ask you, what is the PL? Projection of light बताने लगेंगे, which is perception of light. And many a times we ask कि PL का purpose क्या है? Why are you doing PL? So what does it tell? So they will say कि retinal function बताता है. No, it's optic nerve function that you come to know. PR में projection of rays है, which is so important. We never had access to ultrasound in all vitreous hemorrhage cases we used to, or in cataract also. We used to do a good PR, and the examiner says कि अब PR करो तो तुम लाइट बढ़िया सी चल रही है, ऐसी इसी में PR करने लगोगे, the other eye will not be closed. So make it a habit of doing good examination during your OPD sitting or whatever. Then pupillary reaction is another thing. Many a times people don't close the other eye and do the examination, and the examiner simply asks this. Very simple questions are asked, and when somebody asks you causes of, enumerate the causes, you will tell the rarest of the rare cause. You will forget कि diminution of vision जो है cataract में पहले होती है, refraction में पहले होती है, diabetic maculopathy होगी, age-related macular degeneration होगा. So you have to, like in cystoid macular edema, today we gave a specimen there of OCT that was there. So you have to read the cystoid macular edema thoroughly and properly. अब cystoid macular edema, you get a case of OCT, and तो examiner क्या पूछेगा भाई? यही तो पूछेगा causes क्या है. This is the routine, and only routine cases are asked, and prepare the cases that are usually given. Like आप इसमें जाओगे तो एक आध ट्यूमर का केस मिल सकता है आपको, स्ट्रैबिस्मस लॉन्ग केस में मिल सकता है, यूवेटिस का केस. अब यूवेटिस में देयर आर सो मेनी क्वेश्चंस. simple uveitis with secondary glaucoma, neovascular glaucoma, all these are cases which you get in long case. Neuroophthalmology. In neuroophthalmology, when you check the eye, you have to check all the 12 cranial nerves. I got a case of this facial nerve palsy, and you have to read the Hutchinson, which we used to in MBBS में आपने पढ़ा होगा. सारा cranial nerve का examination you must and practice it. टेस्ट कैसे देखना है, कैसे सेंसेशंस देखने हैं, कैसे उसको हेमीपैरेसिस है कि नहीं, ये सब बताना पड़ेगा, पैरालिसिस है कि नहीं है, क्या है. तो go and see the neuroophthalmology cases and go in the medicine ward and examine them properly. You will not get CT scan in your examination. You cannot diagnose, and the diagnosis is to be done by clinical examination, not by the investigation. You will not get any investigation of the patient. And so these are some of the things that you have to do. In all cases, please don't forget to take intraocular pressure. And in corneal cases, many a time we go in the examination and corneal sensations nobody does. And the examiner would ask कि corneal sensation आपने किए हैं कि नहीं किए हैं. So these are some of the things that you have to remember. And while going for the instruments, as we were discussing in the afternoon also, when you get a case of instrument, you must remember the indications by heart. अब उसमें से एक आध बताने से नहीं चलेगा कि हम नीडल होल्डर लिया है तो हमने इससे सूचर ही लगाते हैं. अब उन्होंने पूछा था कि नेम द फॉरसेप्स, so suddenly you are in trouble. So you, or all the instruments you have to perfectly do properly. Examination has to be proper. HES screening we had not kept. So in this thing you will get HES screening, OCT, fundus fluorescein angiography, corneal topography. All these things are there, and many times we give histology also, which even the examiner does not know how to see the slide properly. Many a times, if you have good friend in the histology department, we have just 1 or 2 slides, and you can know that this is the slide of, by color you can tell that this patient is having retinoblastoma or not. So these are some of the clues. Make good friends with your seniors. They will tell you and they will guide you. सबसे अच्छे टीचर जो होते हैं आपके थर्ड ईयर, जब फर्स्ट ईयर में आप आते हो तो थर्ड ईयर रेजिडेंट होता है या सीनियर रेजिडेंट होगा, तो ही कैन गाइड यू प्रॉपरली एंड यू कैन डू very well in examination. I can see that you have done so well today. All the 5-6 boys and girls, they did so well, and you all know a lot. The problem in our medical education system is that there are colleges where they have not seen a slit lamp even. They examine everything, even the fundus examination they do by torch. They don't even pick their ophthalmoscope. And the other thing which is very important is you get a dark room examination also. So read retinoscopy properly and practice that in your OPD days. That is very, very important, and many a times I find, because our teachers used to say that cataract and refraction is our bread and butter. So you have to practice that, and many a times I find that ki wo, even in the best of the institutions, they will not be able to tell whether this is with the rule astigmatism, what is a Stump's conoid, what is myopia, what are various types of myopia. So they forget, because we are reading all this OCT and all these complicated things which are there for the practical examination. But in long case and short case, you have to practice all these things. And for dark room examination, you must do retinoscopy. That will not only help you in examination, but also in your practice. So these are some of the points that I just simply wanted to say. Thank you so much.
I invite our next speaker, Dr. Murli Manohar J. Yes. He would be speaking how to avoid common mistakes in examination.
Good evening to everybody. I think the students who remain throughout the day and now they deserve for the first attempt pass because they are studious. So all the things have been summarized here. Definitely, I would like to say that how to avoid the common mistakes in your theory, practical, and the Viva voice exam. So that's why you can prepare a best for your exams. Just a minute, please come. You have not started. Yes. So what is exams? An exam is a formal test that you take to show your knowledge or your ability in a particular subject, or you want to obtain a qualification or a degree. That is an exam. So exam is like a girlfriend. Too many questions. Your girlfriend asks too many questions, you have to give the answers. Difficult to understand the girlfriend always. And more explanation is needed from your side, from boy's side. And result is always unpredictable. Yes, no. Finally, she may say yes or she may say no. That is depend upon you. So medical exams can be divided into the three parts. One is the theory, another one is the practical exam, and third one that is the Viva voice exams. The common mistakes what you are doing in the theory, practical, and the Viva voice, we will discuss one by one. You are more panic before the exams in the theory, reading till the last minute when you are entering in the examination, not read the instructions which are given on the top of your the question paper, and not read the questions fully, over excitement on the known question. Yes, I know very well, I can give the answer. Failure to plan your answer. Insufficient diagram, just madam told to you that diagram is to be given, if not asked, but you have to mention it. Leaving easiest question till the last. Yes, I will do this question last. Skipping questions in between. Over spending time on one question. Unable to answer and you become panic again. Failure to plan your time. Beating around the bush. झाड़ी से बेर तोड़ते हैं ऐसे ही मारते हैं और झाड़ी में बेड़ आ जाते हैं, कहाँ आएंगे नहीं आएंगे. Repetition of answer. बार बार एक ही आंसर को रिपीट करना. Use messy handwriting just like me. Bad grammar and wrong spelling. Carelessness. Leaving examination room early, and discussion of the paper later on when you come in your room. The common mistakes which you do in the practical and Viva voice, improper history taking that we discussed already. Bad communication with the patient, just like Dr. Chauhan said. Wrong way of examination, sir already said. Not making probable diagnosis, that is most important, with your history, with your symptoms, with your sign, with your clinical examination, that is probable diagnosis to be made first. That blunders, that should not be happen, and irrelevant answering to be not in the practical and Viva voice. Others are the lack of sleep, excessive caffeine intake, improper diet intake, and insufficient water intake, all may create problem to you. So what happened in the theory exams? What do you feel before 30 minutes before the exam? पेपर बहुत टफ आ जाएगा, पेपर बहुत हार्ड आएगा तो क्या होगा? What if you don't remember the answer? You think that I may not able to give the answer. And sometimes you think that I may not able to finish within the time. All the things to be not discussed, all the things to be removed from your brain. And how to make sure the tension does not affect you. So be relaxed, don't panic, and keep calm and quiet. Reading the last minute, examination hall में जा रहे हो, पढ़ रहे हो, ये that is not good. That you may confusing sometimes. No need to confirm things again and again. And not reading the question paper as well as the questions fully. As I told to you, always read the questions fully. Check the question paper on the both the sides. And then again go back and read again the instruction. Sometimes the instruction given that from the section A, you attempt first, second, third, and from the section B, you attempt first and second. So students should read the instructions fully, questions to be fully understandable, and you should attempt according to that. Not looking at the mark scheme and space provided. Some first question that is of 30 marks, suppose second question is having the A, B, C, and that the A20, B20 and C20. So it is of 60 marks. So give the importance to the second question always. So that will give a good marks to you. Over excitement known question that will blind your brain always. Yeah, I know, मुझे तो बहुत अच्छा आता है, ये तो मैं बहुत अच्छा लिख दूंगा. तो आप क्या करते हो कि जो पूछा उसको भी भूल जाते हो. You may not able to answer properly. Even if question is very simple, please read the question 2 times. Failure to plan your answer. Flow should be equal from start to the last. What happens? You start with the slow handwriting, yes, oh, ah, and lastly, go, then not able to understand. So that a flow should be start to the finish, there should be a same flow. And not using diagram, just madam mentioned, suppose a question in your question paper, first question, give the stages of the diabetic retinopathy and treatment. The question not mentioned that the diagram is needed, but you have to make the diagram in that questions. Stages, maculopathy, you have to draw the diagram according that red color, pencils, you should have. And you should, in every question, this is not mandated that diagram is asked by the examiner, but if needed, you should mention, you should draw the diagram. And leave the easiest question till last. It is not. So what you are doing, that hard question if you attempt first, you will struggling, and you left the question which is very easier. So try to focus on the easier question and then go the hardest question. Skipping the question in between, it is a bad create impression to the examiner. So suppose I am checking the answer book. If the first question, then second A, B, C, third question A, B, C. What happen? Student what do? Third A, then second B, then first, then third C. It is irrelevant. It is not definitely create a bad impression. बहुत ज़बरदस्त इसको लगता है annoying examiner को. So it creates again a bad impression on the examiner. Overspending time on the one question. आप क्या करते हो कि एक क्वेश्चन पे बहुत ज़्यादा टाइम दे देते हो. सो दैट्स वाई द टाइमिंग इज टू बी मेंटेन. यू हैव अ वॉच ऑन योर रिस्ट और ऑन योर टेबल. सो दैट्स वाई यू कैन मैनेज प्रॉपरली. Because I attempt 70 in 10th, I have no watch in 10th standard. So I attempt only 70% questions to attempted. 30% remaining, I was weeping. But definitely 70, I get 67. But you have to manage according to the time management is very important. Unable to answer, don't become panic. Don't give up easily. Take a deep breath, count 1 to 10 or relax, slowly calm down. You may get, your brain may be tired at that time, but by relaxing, your brain may become active and you may get the answer. And again, I told to you, failing to plan your time, that is very important. And if you have short of time, so in last or you have short of time, you may jolt, you boldly, you can say point, this is the point for this question, shorting time. You may give some notes just like, and beating around the bush, as I told to you, that it may create problem. You know the answer properly. You should give that answers to be given properly. Now, repetition of answer. As I saw a book of the UG's optic neuritis short notes, he write down optic neuritis, optic neuritis, optic neuritis, optic neuritis. Optic nerve is a part of the retina. Optic nerve is a part of the fundus. Optic neuritis, optic neuritis, optic neuritis, optic neuritis. Repetition to be not done. Again, if you give an answer timolol, then again not write down the timolol drop. So that has to be prevented. Use messy handwriting, just as I told to you. I am not, my students can able to understand my writing, myself not able to understand my writing. And bad grammar and wrong spelling, that again creates, that grammar should be good, but wrong spelling again creates a bad impression to the examiner. Carelessness, that is very important. Because you are coming in hurry, you not put your roll number, name on the answer sheet you not put, forgetting to bring your ID and admit card, arriving late in there, all the things that may create trouble to you. And leave the examiner's room early. That should not be happening. You should check your answer sheet. You bind the answer sheet properly. If you have take the supplementary answer sheet, you should bind A with the A supplementary answer sheet, B with the B supplementary answer sheet. Check again and again. You have attempted all the questions. So that's why leaving is early is not a good thing. And discuss the paper later on. बाद में हॉस्टल में गए डिस्कस करें, अरे मेरा तो क्वेश्चन गलत हुआ, दैट में क्रिएट इंप्रेशन. वो सामने वाला भी हो सकता है आपको गलत बताए, उसने हो सकता है अटेम्प्ट नहीं किया क्वेश्चन, पर बताएगा ये कि मैंने बहुत अच्छा किया है. So don't become do not discuss in the later on after the examination is over. Theoretical, practical exam and the viva voice. Just sir said, improper history taking is very important because हमारे एक उदाहरण देते थे हमारे सर्जरी के हेड कि एक जैसा आप हिस्ट्री लेते हो प्रेजेंट इलनेस, हिस्ट्री ऑफ पास्ट इलनेस, हिस्ट्री ऑफ फैमिली हिस्ट्री, तो एक को किसी ने जो होता है ना जानवर काऊ ने किसी ने इंजरी कर दी किसी को, तो जो हिस्ट्री लेने वाला उसने पूछा कि पास इधर कभी किसी गाय ने पहले मारा था क्या पास्ट हिस्ट्री में, फैमिली हिस्ट्री में तेरे को माँ बाप को कभी किसी ने मारा था क्या गाय ने. इट शुड बी रिलीवेंट. ये आपको ये नहीं है कि उसकी हिस्ट्री में जान अकॉर्डिंग डिजीज यू कैन आस्क. जो डिजीज इनहेरिटेंस में चलती है, डायबिटीज़ हो, ग्लोकोमा हो, जो इनहेरिटेंस चलती है वो आपको लेनी है. जो इम्प्रॉपर हिस्ट्री आप शुड नॉट बी टेकन इन दी योर एग्जामिनेशन योर हिस्ट्री टेकिंग. And bad communication with the patient, just sir told to us that communication should be patient, should be good, focus, and it should be time efficient. Patient telling, listen properly, never be dismissive, and do not give leading question to the examiner always. आपको जो पूछा है वही बताना है, आपको ऐसे नहीं बताना कि अपना आप सामने वाला examiner कोई आपको leading questions कर सके. Wrong way of examination, just told sir that retinoscopy, if you are doing that PLPR, you are checking in a bright light, that is not, you are doing the direct ophthalmoscopy, suppose right is from the right, left is from the left eye, that has to be create a good impression. So always examination to be done in a routine and a better way and in a correct method. Not making probable diagnosis, as I told to you, probable diagnosis by the analyzing history of the patient, identify the risk, symptoms and the sign, then you formulate a diagnosis, and by the investigation you make your final diagnosis. Just like in the fungal corneal ulcer, if your seborrheic media of chaos staining, if you are able to say that yes, their investigation are in favor of the fungal ulcer, you can make the final diagnosis. But probable diagnosis by your clinical experience, by just looking the ulcer, the hypopion, fungal hypopion, what type of the fungal hypopion picture is, the ulcer is what type, so that you give the probable diagnosis. Final diagnosis with your investigations. And blunders do not, again I am telling, just like in the UG examination, acute congestive glaucoma, the patient, UG student tell, the choice of drug is atropine. That should not be happen in your PG level. Pilocarpine is acute iridocyclate. These are the blunders which may annoying the examiners. Always keep calm. If you don't know, tell the examiner, I don't know. And never argue with the examiner. Never argue with without definite clues. Last time, just 3 days back, I visited the Anantnag Medical College and a UG student tell me that the cigarette smoking, that is nicotine, that may causes the chronic simple glaucoma. I don't know because in Parson and otherwise mentioned, I don't know, but she brings the book and tell me that it has been, so I give a good marks to her. So that's why, if you are sure, then you can tell. Now, irrelevant, inappropriate answering to be avoided. Irrelevant, just like that is not related with the topic, and inappropriate is to be just like in the cataract, if you are telling about the PL, you are telling about the PR, just like sir said. If the visual acuity is telling that you are telling about the ophthalmoscopy, so inappropriate answer and irrelevant answer to not be done. Other factors, just I told to you, sleep to be taken good before the examination. Excessive caffeine intake to be avoided because it may hamper your performance. You may not able to your concentrate your mind during the examination. And improper diet intake. Avoid junk food during examination day. Eat healthy and the balanced diet for before the examination. and insufficient water intake may create problem. So drinking water is pretty much the answer to all of your life's problem. So make sure you stay hydrated during and before the examination, so you not lose your concentration. So no secret bigger than hard work and determination. Keep believing in yourself. Exams completed, nobody can stop me, that should be there. So this is the punchline, and I finished my topic within the time, that is should be the time frame. Thank you so much.
Dr. Santosh, what is the next session?
Yes.
Acha, Rolika is coming.
Thank you so much, sir. That indeed was exactly point on time. Like that was perfect, sir. Thank you, sir, for chairing the session. But please stay back, sir, because you'll be judging the next session as well.
Can I get a cup of tea?
Right, sir. So the next session is Teachers of Tomorrow, Postgraduate Lecture Competition. So this session is quite unique because over here, the presenters are basically the teachers and the rest of us, including the judges, are the students for these teachers. So it's basically to carve and chisel out the trait of teaching amongst the postgraduates and to encourage them to come up on stage and try speaking as from the other side. So I request the judges to please come on this stage. Just one second. Dr. Bhavna Sharma, ma'am, could you please come on the stage? Kamaljeet, sir, please stay back. We'll have tea afterwards again. So, Dr. Rashman Gandhi, sir. Dr. Murli Manohar, sir. Dr. Renuka Srinivasan, ma'am.
Dr. Chauhan is also sitting, please come.
Sir would like to actually.
कुर्सियाँ चाहिए होंगी भाई, नहीं तो झगड़ा हो जाएगा. रश्मिन बॉस चाय.
So we'll just start off the session with the first speaker. So the first teacher, is Dr. Ashwata Alva, and she'll be teaching us on Let's Play Pictionary. I wonder what that is. Let's find out.
Yeah, and as I mentioned yesterday, please make sure that you stay within the time. The time allotted to you is 6 minutes. Make sure that you stay within the time, all right?
Presentation. Let's start.
Many of us have compared the ophthalmic signs to either food that you ate during the day or something right next to you, right? A very good evening to everyone present here. I'm Dr. Ashwata Alva. I'll take you through few of these ophthalmic signs and give you few snippets of flashcard points just to remember better. So it's a little story about Luna. A little girl and the dad is really excited to make her birthday really special. He starts off with a big cake and then brings out a little present. The girl excitedly goes to open it up and she finds surprisingly to see a flower that she's never seen before. The morning glory, which can be compared to the morning glory syndrome. This is a congenital optic disc anomaly, usually due to PAX6 gene mutation, with a large pink disc, funnel-shaped disc, with a central white glial tissue and blood vessels arising out radially. They can be associated with frontal dysplasia and few pituitary abnormalities. As he rolls his cogwheel, he thinks, what can I do to make her little birthday special? And this can be compared to the cogwheel appearance in the X-linked retinoschisis, which is the splitting of the retinal layers, usually occurring in the inferotemporal location among the adults, causing an absolute scotoma, and among the children it occurs as an X-linked juvenile retinoschisis due to a RS1 gene mutation occurring as a bilateral maculopathy, and this gives it the cogwheel appearance. He decides, let's take her to a big gala dinner, starting off with a pizza pie maybe, and this can be compared to the CMV retinitis, which is a necrotizing retinitis causing moderate to severe vitritis occurring in an indolent and a fulminant form. The fulminant form causes wide retinal exudates with retinal hemorrhages, giving it the pizza pie appearance. These patients usually have a CD4 count of less than 50, and they're immediately started with heart therapy and anti-CMV therapy like valcyclovir, ganciclovir and foscarnet. He says, some scrambled eggs too, little girl, and this can be compared to the best vitelliform disease, which is the second most common autosomal dominant macular dystrophy following the Stargardt's disease. This is caused due to BEST1 mutation occurring through various stages. The first round yellow egg yolk appearance is the vitelliform stage, going through pseudohypopyon, then it breaks up to the vitally eruptive stage with a scrambled egg appearance, and finally the atropic stage. When these patients have a choroidal neovascular membrane, it's best to give them an anti-VEGF treatment. The bakery next door has a really good Swiss cheese. Want to try it? She says, and this is the band-shaped keratopathy, which is a deposition of calcium and hydroxyapatite in the stroma and the anterior stromal layers. This occurs due to chronic uveitis glaucoma, phthisis bulbi, and a silicon-filled globe. These patients are treated with scraping off the epithelium and chelating with EDTA. That was wonderful, Daddy. Can I have an extra slice of cheese? She says, and this can be compared to the acute retinal necrosis with maybe some salt and pepper. This salt and pepper retinopathy occurs in the congenital rubella syndrome and the Kahn-Sayre syndrome. Kahn-Sayre syndrome is a mitochondrial myopathy causing a progressive ptosis with external ophthalmoplegia. They have a pigmentary retinopathy, which is like the salt and pepper appearance. The Marsan stain gives a ragged red fibers. The dad wears his hat and mustache, and tells her, let's get you some more presents. This can be compared to the OCT signs of lamellar macular hole. His collar stud that he wears looks very much like the choroidal melanoma on the B scan. He gets her more presents, and these are some white pearls like the pearl-like appearance in the cystoid macular edema, and a little beautiful flower like the flower petal appearance on the optic disc. As the sun sets, it is compared to the VKH syndrome, and this is a bilateral granulomatous panuveitis going through various stages, and the final stage gives a sunset glow. These patients have alopecia and vitiligo and lymphocytic pleocytosis. That was a wonderful day they had, right? Finally, to end the day, he says, let me show you the stars in the sky. And these stars in the sky can be compared to the hyperfluorescent spots on an FFP in the VKH syndrome. So that was my story of little Luna. As she goes around jumping up and down, the dad is really happy and puts her to sleep. He asks her, what would you dream about tonight? And she screams, UFO, Daddy, UFO. This UFO is compared to the plaquenil maculopathy caused by hydroxychloroquine, which is an ISOS atrophy. So every teacher ends the presentation with a few questions, right? Would you be my good students by answering some really easy ones? Let's start off with this. Come on, give me. Excellent. The tomato splash appearance with CRVO. This one? Candle wax dippings in sarcoidosis. Great. And December 25th for Christmas tree, which is seen in myotonic dystrophy. Great students, I'm saying you, great students. I'm a proud teacher now. And finally, the bear walks in the paw, and what do you see there? In which condition? Yes, great. That's congenital hypertrophy of retinal pigment epithelium. And finally, the golden rain comes down, suggesting synchisis scintillans. Thank you so much for being wonderful students and giving me opportunity to be a nice teacher.
Thank you, ma'am. Ma'am, I just had a question, ma'am. I had ma'am, some other teacher was telling ma'am that CHRP can have some systemic association. I forgot, ma'am. What is that? If you see CHRP, you're supposed to do some other multi-specialty consultation is what I heard, ma'am, but I don't
Yeah, a
remember.
neurologist opinion, I think, should be
Just because I asked. No. No,
Well-
gastroenterology. They are at higher risk of carcinoma colon.
You have done wonderful presentation, because once I was asking from my student what is salt and pepper appearance, he said ki namak or kagaj. Salt and pepper. He said salt and pepper, sir. इसमें क्या है sir? नमक और कागज. तो which is pepper. So you have rightly done. Wonderful picturization, wonderful pictures. Great.
Very nice presentation. Just one thing I wish to add, that since all these were macular and by and large genetic predisposition, so I would would suggest that you would have, although it was a good presentation, that the ICD-9 classification you could have added, because that was a uniform group. So, okay.
Good presentation,
Yes,
but
like-
the main thing that you have not used your indicator properly. You have in the hand, but no one you have used. That should be.
All right. Thank you so much. Can I have Dr. Zainab, please?
Yeah, good evening. So I am Dr. Zainab. So these days you see a lot of kids wearing spectacles, small, very like from 1 year to approximately 16, 17 years. But do you know how to prescribe glasses to them? Like a 1-year-old comes to your OPD, how will you prescribe glasses to them? So I'm going to talk about that problem. So suppose a mother comes to your OPD with her child complaining that my child has blurring of vision, or he or she cannot read properly, or has some deviation in either eye, or she says that he or she sits very close to the television while watching the television, or his or her performance in the school is just deteriorating and is not performing too well. So what will be the first diagnosis? So refractive error is the most common cause of reduced vision in such children. It is also responsible for 60 to 80% of visual impairment in children. And management of refractive error is the most common problem faced by today's ophthalmologists when examining the pediatric patients. So what are the difficulties faced these days? So first of all, subjective refraction is really very difficult. If a really small child comes, he or she cannot speak. So you cannot at all perform subjective refraction in that child. Also, objective post-refraction often depends only upon the retinoscopy findings, which is done by the examiner. The change in the refractive status in infants and toddlers is very fast, and hence constant monitoring is required in such children. So a gold standard in pediatric refraction is a good retinoscopy. Even although school-going children cooperate on the autorefractors also, so it can be used with proper and appropriate cycloplasia. So which cycloplegics to be used? Mainly atropine, cyclopentolate, and homatropine are commonly used cycloplegics. Here are the conditions. If the child has esotropia and if the child is less than 5 years old, atropine is used, which is the strongest cycloplegic. The parent is given prescribed atropine ointment and asked to put a rice grain size ointment into the child's eye near the punctum daily twice. In the child's eye, and return after 3 days to the ophthalmologist. And if the patient is more than 5 years, either cyclopentolate or homatropine. And if the child does not have any squint, same cyclopentolate or homatropine eye drops are used. Also, exact retinoscopy readings are not prescribed. The working distance and cycloplegic agents used are subtracted from the retinoscopy readings. But in case of pediatric hypermetropia with esotropia, complete correction subtracting only the working distance has to be prescribed irrespective of the age. Now, appropriate refractive correction is prescribed in infants and young children by performing a post-mediatic test if the patient does cooperate for a post-mediatic test, or is given a prescription based on the recommendation of the National Consensus Statement regarding pediatric eye examination, refraction, and amblyopia management. So this is the category given by the National Consensus Statement, how you will prescribe the following children. Also, in children with global developmental delay, the following prescription criteria is used after wet retinoscopy. And patients with CVI, which is cerebral visual impairment, glasses will be offered by adding +3 diopter spheres added to the full cycloplegic refraction. In special situations like full correction in accommodative esotropia, hypermetropia corrected in exotropia only if vision is affected, or high hypermetropia more than +4 diopter, and bifocal with lower segment cutting pupil in case of esotropia with high accommodative convergence to accommodation ratio. Last but not the least, the dynamic retinoscopy. It allows a quick assessment of the patient's ability to accommodate. The examiner begins by neutralizing the refractive error while the patient fixates on a distant target, and working distance lens is then removed and the patient is asked to the near accommodative target, which is held next to a retinoscope. If the patient is able to accommodate the near target, the examiner should see the motion reflex change to neutralization. If not, the examiner moves to and fro on the either eye to see the neutralization. Patients with high hypermetropia or amblyopia, symptomatic accommodative insufficiency is noted, which should be corrected by prescription of near correction, which may relieve the asthenopic symptoms faced by the patient. Thank you.
Very nice, Dr. Zainab. Very beautifully covered and a nice presentation as well. Just a suggestion that a lot of times when you are here as a teacher, so a lot of slides that you had were very busy slides. So maybe you can declutter it a little bit to make sure that you have just the points there. That's why it's called PowerPoint. Have points there and then you elaborate on the points.
It's very interesting topic. Actually, it's very close to my heart. Prescribing the glasses to the children is very, very important, and we don't know exactly how much correction we are going to give. Like in esotropia, the full correction, as you have rightly said, it should be given. And if the squint is not there, then you can even undercorrect. So for the benefit that the patient starts wearing the glasses. But if a squint is there, then you have to give full correction. Why is it so?
So the accommodative power of the patient is very high, and so that's why the patient starts squinting. So this child might go into refractive accommodative esotropia because of the high
There are, what are the types of hypermetropia? Facultative, obligatory, and what is
latent? And total known as the? Sir, पूछ रहे ना?
It's okay.
Yes, ma'am. Okay.
So
Okay,
you have not mentioned the retinoscopy which needed to be done in the children, that is the streak or the simple mirror, which you only shows the streak retinoscopy. Why not the?
Sir, even you can do it on Priestley-Smith retinoscope, can be used while doing the retinoscopy, but usually the children are very uncooperative. So for our convenience, we can use a streak retinoscope. Otherwise, retinoscopy can also be done on a Priestley-Smith retinoscope.
And second thing, you are not tell about the handheld autorefractometry.
Yes.
That has to be used in the children. Yes. Only in the children. Okay.
Very nice. Thank you so much.
You.
Very nice. Good presentation. So she has laid the importance of retinoscopy in strabismus in children. So you must not forget doing this job.
And the best indication is if the child squints. It is a must. Otherwise, we will not even know if there's a refractive error. And in present times, with prematurity on the rise, it should be a routine examination because there are a lot more refractive errors than earlier. Thanks to prematurity and the the kind of devices which children are using and online learning.
Dr. Dwij here. Dr. Dwij Shah. Yeah.
Hello. Good evening, everyone. Today my topic, eye as a window to your subconscious. It's just out of the box topic, and from my 2 years of experience only, I'm too early also, but...
Be a little louder, please.
Madam, is it okay?
You're fine.
Okay.
Be loud.
It's just an out of a box topic, and from my 2 years of observation only, I'm observing in the ophthalmology field, and if I will give a chance, I would like to go further in this direction. As an ophthalmologist, we are seeing from patient's eye only so many things, and we are known that eye is a very expressive organ, and if you see in someone eyes also while looking constantly, they will get offended, that they will get to know somehow what in their mind going on. But what we are doing is constantly seeing in their eye. So they are in constant fear that their subconscious is going to be read. And as we are very near to them, we can get to know about so many things about the patients by eyes only. And eye is so much expressive, though not much research has done. But 90% of the information transmitted to the brain is visual. In the visual cortex also, it is processing more than 60,000 compared to the other perceptions. And most of the movements of the eyes are controlled by involuntary. So it is a true expressions of our brain. Give a maximum space and more than 50% of the cortex. And as the eye is transparent to light going inside also, it is as much transparent for the expressions for the outside, 100% it is expressing. And we can help if we connect the psychology and the eye, our psychiatry of people also, by, as the patients are very afraid to go to psychiatrists nowadays, so if we can get to know about the patient's psychiatric problem or any psychological defect in the patient, we can guide them patient to the psychiatrist, because ophthalmologists, they will frequently come without any problem also they will come, but in psychiatry they will not go. Mainly 4 functions I have researched about this, and 4 components we can focus further research in the connection with the psychology. First is pupillary reaction. Pupillary reaction not just limited to ICOS and RAPD. It's a basic rule. More the size, more the attention person is giving to you. It is done study in the Georgia Institute also, and we can use this basic fact just to implement in the ophthalmology, and we can correlate this fact in so many field in the market also. Like in online shopping, we can guide them that if they have allow us to front camera, we can see the person's pupillary dilatation, and if person is getting bigger dilatation while seeing some items, they are interested in that item, and we can increase the price of that thing. Extraocular movements. If I'm looking forward to the doors constantly, that means it is my outside eye is going that way, means my subconscious is going that I want to go out from the room. So like that only, if I'm looking left while talking, it means I'm looking from my left cortex, and if I'm lefty, I am telling something fabricated. Like that, we can use this kind of facts in crime, solving crime also. In glaucoma also we can use, we are constantly asking patient that आपने ड्रॉप लिया है नहीं लिया है, अगर वो सोच के बता रहा है लेफ्ट साइड में लेफ्टी है तो वो झूठ बोल रहा है. That kind of thing we can use. Blinking and tear film in dry eye disease we are constantly using, and luckily some research has done in this area also, and connection of basic tear film and production and emotional state is already proven, and we can use this kind of psychology in this dry eye disease, and we have to refer some patients, if we can know about their psychology in the dry eyes, we have to refer to psychiatrists, because there are so many literatures, they are connecting the dry eyes and the psychiatry. Eyebrows, micro expressions, we can get to know from patients' eyebrows also so many things, and we can decide patient is interested in surgery or not also. And sometimes patient's expression can be related to their subconscious mind, and that can give us the, again, implementation in crime branch. We can help the crime people to solve the, if patient is, like, if crime done, accused is telling truth or not. So conclusion is, there is a requirement of connection between psychiatry and ophthalmology. It can be psycho-ophtho, we can say that. And in this time, there are so many layers in the personality of the persons. So we can help some other branch like psychology and psychiatry to decode the eye language of the patients. And this implementation, as I have already told, that can be helpful in medical and commercial ways both. Thank you.
Thank you, Dwij. I love how many startups you have already. I love the way you spoke about pupil and
A very
the mall.
sublime topic, huh?
Yeah, and it's very interesting because I work with an institution called Triple IT. It's an IT institution in Hyderabad, and we have two projects on pupil reaction. One is already in sort of in a social area, not in scientific area, where they are looking at pupil as a marker, one for alcohol, so they don't have to then check the breath, and second, for the rapist. They have been, the team has been evaluating, having a huge questionnaire, and one of the markers is pupil. And they seem to have some amount of, I mean, it's too early to say, but they seem to have some amount of indication that pupil probably can be used in those patients.
Okay.
It looks like you're starting a new branch of ophthalmology.
I'm
Excellent
too young,
imagination.
madam,
That's very good thought. Very thought-provoking.
It is artificial intelligence.
No wonder, yes.
ऐसे
But,
जो है ना गुरुजी लोग पकड़ लेते हैं कि पढ़ के आए हो कि नहीं आए हो और कई बार वाइवा देते समय जब लोग ऊपर देखने लगते हैं तो हमारे टीचर कहते थे ऊपर कुछ नहीं लिखा सामने देखो.
Well, your slides could have been a little better, I thought, because some are having just one or two lines and they are full sentences. You never have full sentences. You should just have keywords. No, I'm just saying.
Actually, I don't know that I got accepted in this.
Yeah,
so
anyway, you could have named the top thing more than what meets the eye. That would have been a good header.
Thank you, ma'am.
Thanks.
Thank you.
Good presentation, something new to our.
Do you have Dr. Charu here? Yeah.
So, good evening, everyone. So, topic of my presentation today is the limbus. Since for any ophthalmic surgeon, it's very important.
Charu, can you tell which medical college you come from? And I request all the participants to inform this also, yes.
I'm DNB resident from Thindai Hospital. So my topic for today is the limbus, and since it's very important for any ophthalmic surgeon to be very well versed with the boundaries of limbus, hence I named my topic as the surgeon's playfield, the limbus. So we shall be dealing with the histological, anatomical, and the surgical perspective of the limbus in today's session. So we know that limbus is actually this transition zone between the cornea and the conjunctival epithelium, or the cornea and the sclera. So, but grossly, the limbus is actually not spherical, it's actually elliptical. It's having more dimensions in the vertical meridian as compared to the horizontal meridian. And this is the reason why the cornea is having more diameter in the horizontal dimensions as compared to the vertical diameter. So let's deal with the histological limbus first. So as I mentioned earlier, that limbus is a transition from the cornea to the conjunctiva. So while we deal with the limbus from the histological perspective, I shall be dealing with all these layers one by one. So we all know the very first layer of the conjunctiva hair is the conjunctival epithelium, and the cornea is the corneal epithelium. So the limbus is the histological limbus is defined as the transition from the corneal epithelium to the conjunctival epithelium. So this transition has been marked here in the pink color, and these are the palisades of Waugh, which are known to have the limbal stem cells. Now the second layer of the cornea is the Bowman's membrane, and the second layer from the conjunctiva is the substantia propria. So the second definition for the histological limbus is the transition from the Bowman's to the substantia propria. Now the third layer of the cornea is the corneal stroma. Now what's below the conjunctiva? We actually have the tenons, and then we have the episclera, but then they are ending before the termination, before the starting of the limbus. So immediately below the episclera is the sclera. So the third definition becomes where the corneal stroma continues with the sclera. Then the fourth layer we have is the Descemet's membrane, and here we do have is the termination of the Descemet's membrane at the limbus is what is known as the Schwalbe's line. Now the fifth layer of the cornea is the corneal endothelium, and it forms the epithelium of the trabecular meshwork. So this is as simple as I have shown. So this is the definition for the histological limbus. Now anatomically, the limbus is defined as a zone. So this zone is having an interior boundary which has been marked here as a continuation from the Bowman's to the Descemet's, and a posterior boundary which is continuing from the perpendicular which is drawn from the scleral spur to the globe of the eye. Now we are going to apply this anatomical and the histological knowledge to define what is surgical limbus. So that is very important before we plan to jump into any type of cataract or the glaucoma surgery. So surgically, limbus is divided into two zones, the blue zone as has been shown here and the gray zone. Now, this zone has been divided into two zones by the three boundaries. The first boundary is the interior limbal border. Now, how to see this interior limbal border? The book says that interior limbal border is the point where the Bowman's membrane ends. But when we are doing surgery, we might not able to see it. So to mark this, the termination of the Bowman's membrane, we do have these vessels to help us. So the termination of these ciliary vessels is the boundary of the interior limbal border. But this blue zone is not the same. As I mentioned, that the limbus is not spherical, it's actually elliptical. It is having more boundaries in the vertical dimensions. So it is the thickest portion, that is 1 mm, followed by inferiorly 0.8 mm, and then both nasal and temporal is 0.4 mm. So this is what forms the blue zone. And then we have this mid-limbal line, which is the termination of the Descemet's membrane, that is the Schwalbe's line. And then the third zone, the second zone is the gray zone, and the gray zone is marked by is extending from the mid-limbal line to the posterior limbal border. Now this posterior limbal border is where the scleral spur is, and hence the gray zone is the area which is just above the trabecular meshwork. Now why I am mentioning all these boundaries and why they are very important for all of us to know is because they help us to plan the incision. Now in case we decided to make the incision in the cornea or in anywhere in the blue zone, so that incision will be going through the Descemet's membrane, and it can lead to the Descemet membrane detachment, okay? So second thing is that if we plan to make the incision in the mid-limbal line, that most of the surgeons does and is most preferred site, is the termination of the Descemet's membrane, that is the Schwalbe's line, and it is considered to be the safest zone to make the incision. And the third area is if we plan the incision in the gray zone, so that is just above the trabecular meshwork, so we may injure the trabecular meshwork. And in case we plan the incision more posteriorly, we can injure ciliary body band, and it can lead to the hemorrhage in our surgery. So that is why I want all of you to get well versed with all these boundaries. Thank you.
Very well illustrated with good slides. But just a little acne, you should also talk about the applied aspect. It's not just about surgery, it's also about certain therapeutic measures. The limbus is a highly mitotic area,
Yes,
and you should have gone a little more into the stem cells, because that has become a form of treatment. Stem cell transplant is the treatment of many epithelial disorders, isn't it? A little bit on that could be good. And what this white to white diameter, that's become an important parameter also now. Otherwise, very good presentation with good diagrams or whatever. Thanks.
Good presentation,
Thank
definitely.
you, sir. Thank you.
You focused on whatever you wanted to present. You wanted to present the surgical, reference to this limbus, so you presented on that only.
Yes, sir.
That is good. And overall a good presentation. Your expression and execution was also good. Only thing, as madam said, that maybe you could have added, a bit of applied anatomy of limbus as well.
Okay.
The cell multiplication that you missed on the mitosis and the 7 days phase and the XY
XY
hypothesis. Maybe that was missing in that. That's all. Otherwise, a good presentation overall.
Thank you, ma'am. Thank you, everyone.
I hope you know about the XY hypothesis
Yes,
and thought.
ma'am. Yes, ma'am.
Because should you tell this to examiner, the next question would be this. Okay.
So,
Thank you. Thank you, Charu.
thank you.
Next is Dr. Anushri Lingaya.
Can I start? Good evening to the judges and everybody sitting here. I'm Dr. Anushri from SDM Medical College, Dharwad, and this is going to be my topic. So, what do you think this is? It's a granite coffee table. Why am I even talking about it? And this is like a stone. Probably the table is made of this stone. And this, do you think it's a stone? No, it's not a stone. It's a hard brown cataract, or almost a black cataract that was extracted by my mentor through an SICS surgery. So today I will be talking to you about this rock hard cataracts, also colloquially known as cataracts. They're hard because of the nuclear sclerosis, and they become brown or black due to the accumulation of the photooxidation pigment urochrome. It is definitely challenging and daunting even for most experienced surgeons to get this cataract out of the eye, and let alone phacoemulsification definitely needs the courage of a warrior to get the rock hard cataract out. So we do face many challenges, and as told by a Chinese military journal written in his book of The Art of War, know your enemy and know yourself, and you can fight 100 battles without a disaster. So what are the challenges that we encountered with these hard cataracts? They have low endothelial cell counts, and hence the risk of post-op corneal edema, a small pupil, which we must anticipate before the surgery. The color of the lens and the iris, everything looks the same. The anterior capsule is so indistinguishable, and both the anterior and the posterior capsule are very thinned out, leading to many complications during the surgery. And the zonules are almost, they're very weak. They can be very weak or even partially absent. The lens fibers are so adherent, and it's definitely a Herculean task to get it out by a phaco chopper. And there is no cortical cushion between the lens and the capsule, so it makes the surgery all the more difficult, and there is wound burn because of the high energy needed by the phaco. And all this results in excessive post-op inflammation. And definitely doing a surgery and evaluating these patients is like walking on a thin ice. And a thorough history should be taken, like a history of anticoagulants and history of use of drugs like tamsulosin to prevent floppy iris intraocularly. All this makes the surgery even more difficult. So on examination, we have to check the vision potential of the patient by checking PL and PR, the intraocular pressure, the AC depth if the lens is subluxated, and if there is any phacodonesis, which will tell us about the zonules, the density of the cataract, and definitely what's the maximum pupil size on dilatation. And we need to do a B-scan ultrasound to look for the retina status, and if we have a specular microscopy to check for the endothelial cell density, as they have poor endothelium. And how do we tackle these rock hard cataracts? If we are doing a SICS, definitely a larger tunnel and a larger rhexis. The rhexis can be even converted to a capsulotomy or relaxing cuts if needed, if it's not adequate enough. And if a phaco is done, then definitely a larger rhexis of 5.5 mm to 6 mm. And protecting the endothelium with lot of dispersive viscoelastic substance. And tryptophan blue is our friend here, because the anterior capsule is absolutely not visible, and this stains it blue, and hence making it visible. A gentle hydrodissection is preferred since the capsule is thin, and it can lead to capsular blowout if the hydrodissection is too vigorous. If it's a phacosurgery, definitely a big central groove will help to catch the nucleus, and a soft shell technique where the cohesive visco is injected near the nuclear chunk, and dispersive to coat the endothelium is preferred, so that the energy dissipated is lesser. And dividing the nucleus into multiple small fragments within the bag is a better technique, and if the phaco machine has a torsional energy setting, that would be preferred. To minimize the lens chatter and turbulence, right parameters are needed, like a high vacuum and a moderate amount of phaco energy. So there are different kinds of phaco techniques. Better ones are like crater and chop with 90% thickness, where the crater is made, and other techniques like drill and crack, tilt and crack are used. The complications because of the condition, due to the condition of the endothelium of these kind of patients, there is a risk of corneal edema post-operatively, leading to pseudophakic bullous keratopathy. They can land up in that if proper care is not taken. And during the surgery, there can be a capsular blowout because of the thin capsule, resulting in a nucleus drop. There can be PC rent at any stage, even during the IA because of the thin capsule. If the zonules are weak, even before anything is done, a back dialysis can happen. So the recent advances in this is femtosecond laser-assisted cataract surgery. Also, another recent advance is the MyLoop. Basically, this is like a thin wired loop which will grasp the nucleus, and it will crush the nucleus into multiple pieces by applying a centripetal force. So all other things what we do by dividing using a vertical chopper, all of that apply a centrifugal force, applying stress on the zonules. But this MyLoop is a centripetal force. The force is directed towards the center, and the stress is lesser. So this is a newer equipment. These are my references. Thank you.
For the beginners, I would suggest that in such kind of hard cataracts or granite cataracts, as you have called, SICS should be planned, and a big incision, which means that you have to be even 7.5 mm, and inner wound should be even larger, so that when you come out of, deliver the nucleus out, you don't touch the endothelium, which is very, very important. Compared to this, if you are doing phacoemulsification, the technique that you have described is also good, but making a large rhexis, as you have said, because many a times when you are doing direct chop, you might touch the capsular rhexis and you can cause problem there. So what you have to do is that you have to do, and prepare to convert, as madam has said, and do a divide and conquer technique. For divide and conquer, you will have to use higher power, less vacuum, and trenching should be done in 4 quadrant. Then you can, if once you can break the back of the nucleus, then you can easily take out with this. But I would suggest that for 10 years at least, in your practice, don't try phacoemulsification in these granite cataracts. Okay? Thank you.
And don't hesitate to apply the suture. That is, sir said in SICS, if you give the large incision, that may leaking out. So don't hesitate to give. And in phaco, if you are doing in this hard cataract Niagara, so you divide with the help of the chopper and one with the help of the dialer. So that will plate that plate. If you see the red reflex clearly, stop at it. Otherwise, you may go in the posterior capsule and posterior capsule may rupture. Yes. And always setting is more important for this time in the phacoemulsification of a hard cataract.
Okay, thank you. Thanks. We'll have the next speaker, please.
Do we have Dr. Shweta?
Good evening, everyone. My name is Dr. Shweta Samuel. Is ulta glaucoma, which is just my poor attempt at a joke on the topic aqueous misdirection. So let's consider a scenario. We have a patient post-trabeculectomy presenting with an acute red eye. On examination, we see a shallow AC, shallow both in the periphery and centrally, an elevated IOP, and we note the presence of a patent PI. So what must we think of? First, a patient with a high IOP and a shallow AC, we must think about pupillary block glaucoma. However, in these patients, the AC will be deeper centrally because this mechanism is due to a pupillary iridolenticular contact, which leads to upward bowing of the iris, causing iris bombing. And more importantly, if there is a patent PI, this condition is relieved and we will have a deeper AC because of the re-establishment of flow of the aqueous. Secondly, we must think of overfiltration or bleb leak. Overfiltration is evident by a diffusely large bleb, and for the leak, we can do a Siedel's test to rule it out. And we must also think of choroidal detachment or suprachoroidal hemorrhage. In this condition, if the fundus is visible, we can see brown bullous elevations, or if the fundus is not visible, we can perform a B scan to see the classical dome-shaped elevations. So what are we left with? The conditions, the symptoms I mentioned earlier, and now we've confirmed a normal posterior segment and a patent iridotomy. This is what aqueous misdirection is. Why did we go about it this way? Because it is a diagnosis of exclusion. It occurs in only 0.6 to 4%. And its classical presentation is a unilateral painful red eye in the early post-operative period, usually after incisional surgeries. However, it can occur at any time, and the IOP can be normal. So there are several theories put as to why this happens, which give it several names. But the basic concept is this. Normally, aqueous from the ciliary body flows via the pupil into the anterior chamber. In this condition, there is an abnormal relationship between the lens, the vitreous, and the ciliary body, leading to ciliar lenticular contact in the equatorial region of the lens. This causes backward or ulta flow of the aqueous into the vitreous, causing a block here, and it takes the path of least resistance. Now this causes a unilateral valve mechanism which leads to a constant cycle of aqueous hydration and condensation of the vitreous. This condensation further prevents the aqueous from moving out and causes an increased pressure differential in the posterior segment, leading to the forward movement of the iris lens diaphragm, precipitating an attack of malignant glaucoma, which is another name for this condition. So there are certain risk factors we must note pre-operatively that will help us be extra vigilant in the post-op period looking out for this condition. These are some clinical pictures. We can see that the anterior chamber is shallow both centrally and peripherally. And AS-OCT shows us anteriorly rotated ciliary body with iridolenticular contact more clearly visible in the UBM. This is a normal patient, and this is a patient with malignant glaucoma. You can see the anterior rotation and iridocorneal contact. So how do we manage this? So the two main things that we must take note is we should either relieve the ciliary block, or we try to make the eye unicameral and relieve that pressure differential. So we can first try medical therapy. So the mainstay is topical cycloplegics. So this acts by contracting the ciliary body, tightening the zonules, pulling the lens back in an attempt to break the ciliary block. Adjuvantly, we give aqueous suppressants to reduce the aqueous flow, hyperosmotic agents to reduce the pressure of the vitreous. However, the success is only there in 50% of the patients. And if it does not work within 4 to 5 days, we move on to the next line, where we can try lasers to perform an Nd:YAG laser capsulotomy plus hyaloidotomy. In pseudophakic and aphakic patients, we can go through the pupil. In phakic patients, if there is a large enough PI and there's good visibility, we can try to go through the PI to make the eye unicameral and relieve the pressure. We can also try argon laser photocoagulation of the ciliary processes or transscleral laser cyclophotocoagulation. So this shrinks the ciliary body and attempts to move it backwards. But the success is noted by moderate deepening of the AC within 24 hours. If this does not occur, we must move on to surgical line of therapy, where the main principle is to make the eye unicameral. In pseudo and aphakic patients, we try to perform an iridectomy, hyaloidozonialectomy, and a vitrectomy. In phakic patients, we must add lens extraction and IOL implantation as well. So earlier, one of the first methods, surgical methods, was a posterior sclerotomy and air injection into the AC to reform it. And if we can't do any of these, we can try a slit lamp needle revision if the anterior hyaloid is visible in the AC in aphakic patients. So this is a summary of the treatment. And this is a picture pre and post-treatment. And we must also take care to protect the fellow eye. We must do a prophylactic PI, and if we are planning for an incisional surgery, intra and post-operative cycloplegic and mydriatic therapy must be given, and we must avoid miotics because this can precipitate the attack. These were my sources. Thank you so much for your time.
Some very good slides, wonderful.
Slides, good explanations. Can drugs also cause?
Yes, ma'am.
Have been reported?
Yes, ma'am. Like for one.
Which drug?
If you use pilocarpine.
Yes, pilocarpine. I mean, nowadays it's not used, but it's also notorious. And pre-operative use of pilocarpine also is a predisposing factor for a post-operative this one. Very good and good illustrations. Thanks very much.
Thank you, ma'am.
Most often, vitrectomy will not be required. It's is there a role of anterior vitrectomy?
Yes,
procedure called anterior vitrectomy. That is if that means either or a capsulotomy, posterior capsulotomy can also release that pressure from behind in a aphakic eye or a pseudophakic eye. Thanks.
Good evening, everyone. I'll be discussing about chorioretinitis scleropateria and how understanding the meaning of this word helps us to remember the condition better. I'm a final year resident in JIPMER and my mentor is Dr. Shreyas. So, the term chorioretinitis scleropateria was first described by German ophthalmologist Hermann Kohn. Now, let us understand the meaning of the words chorioretinitis and scleropateria. As we all know, chorioretinitis means there is inflammation of choroid and retina. The word scleropateria is derived from two words. Sclo in Old English means scratching or clawing, and scleropatum in Latin means a long weapon like a gun. So, basically, chorioretinitis scleropateria means that there is a scratch on the globe by a projectile leading to rupture of choroid and retina. This is fundus image of chorioretinitis scleropateria. Coming to the other names of chorioretinitis scleropateria, it is also known as traumatic chorioretinal rupture, obviously because there is history of trauma leading to chorioretinal rupture. It is also known as chorioretinitis proliferans. This is because in chorioretinitis scleropateria, there is proliferation of fibroglial tissue leading to scar formation, which are depicted in these two fundus images. Now let us understand the pathogenesis of chorioretinitis scleropateria. It is a rare closed globe injury. Remember, though it is caused by a bullet, there is no component of open globe injury in chorioretinitis scleropateria, and it is a closed globe injury. As you can see in this picture, when a high velocity projectile passes close to the sclera, it creates shock waves which are transmitted onto the globe. This leads to rupture and retraction of adjacent chorioretina. There will be associated rupture of vessels leading to subretinal and vitreous hemorrhages, which are depicted in this fundus image. This heals with fibroglial scar with bare sclera. This fundus image shows the fibroglial proliferation and scar formation, and this shows the bare sclera. Now let us discuss the clinical features of chorioretinitis scleropateria. There will be decreased visual acuity. The patient can complain of blurry vision or vision loss. There can be extraocular muscle defect. This is because of the lodged pellet. When the disc is involved, there can be a relative afferent pupillary defect. There can be hemorrhages at various levels like vitreous hemorrhage, subyloid hemorrhage, and intraretinal hemorrhage of the posterior pole, and there can be elevated intraocular pressure. Now let us discuss the clinical appearance of chorioretinitis scleropateria. In acute presentation, there will be hemorrhages at various levels, as you can see in this picture. There will be bare sclera, and in late presentations, there will be fibroglial proliferation with scar formation. Again, this slide shows the various presentations of chorioretinitis scleropateria. These three are acute presentations showing hemorrhages at various levels, and these images are late presentations showing fibroglial scar formation. Now coming to the investigations done for a case of chorioretinitis scleropateria, we have to do neuroimaging, that is CT scan. This is a case of chorioretinitis scleropateria, and the CT scan shows orbital pellet. Wide field fundus photography shows wide area of fibroglial scar, and the corresponding fundus autofluorescence shows hypoautofluorescence in the area of chorioretinal rupture. Ultrasound B scan can be done to rule out orbital foreign body, which is seen in this case, and OCT can be done. OCT will show rupture through the choroid, retinal pigment epithelium, and outer retina, as you can see in this picture. C fields, if done, will show corresponding field defect. Coming to the treatment of chorioretinitis scleropateria, the treatment of choice is observation in most cases. Few cases may need procedures like orbital foreign body removal, globe exploration, and pars plana vitrectomy. Pars plana vitrectomy is indicated when there is retinal detachment or when there is non-resolving vitreous hemorrhage. Coming to the prognosis of chorioretinitis scleropateria, there is a low risk of retinal detachment in these cases because of the full thickness chorioretinal scar. The visual prognosis depends on the type of injury, object of injury, location of primary penetration, and location of rupture. That is, whenever there is macular involvement, the visual prognosis will be poor. Most patients of chorioretinitis scleropateria experience improvement in final best corrected visual acuity from the time of injury. but only less than 20% of patients achieve a vision of 6/6. These are my references. Thank you.
Okay, anyway, you revived a less often used word because now it's just called traumatic chorioretinitis, and probably this is the late stage, isn't it, of a rupture?
Yes.
So when it is in the fresh stage, it is called a rupture globe, and it's often due to open globe injury due to blunt trauma. And rarely, I suppose, it affects the macula, fortunately. But if it is neglected, it will appear like a chorioretinitis. As he says, it doesn't cause regmas, doesn't cause sores because there is a sterile inflammation around that, and it may present later as a traumatic chorioretinitis. Yes, this is a very good discourse on a less used topic, and I think all of the entire audience will take this home. And I hope we can all spell it as well as pronounce it. So it's a very rare word. Thanks very much.
Thank you.
Good evening all. Today I am going to present the topic nystagmus. As we all admit that nystagmus is a very boring topic. And
Other girl is not there? No, she's not. You are Rukhaya Khan, optic disc.
Yes, sir. Okay.
And don't say it's a boring topic. Tomorrow there is a class.
Not a very interesting topic.
Good.
Correcting myself. Today I'm going to present nystagmus, and as we all admit that it is not a very interesting topic. So I'll try to simplify it, especially the management part with my weird mnemonics. So let's get started. So we all know the definition, and there are conventionally there are many
Classification.
sorry. So conventionally there are many measures to describe the nystagmus, but especially I want you to notice the null zone. So what is null zone? Is a field of case in which the intensity of nystagmus is minimal. So the cases of nystagmus that have an eccentric null point, they assume the head posture. So let's say the null is in dextroversion, let's say the null is in right, the face turn is towards the left. Similarly, if the null is in left, the face turn is towards the right. So they all are secondary measures and they do not give much information. The primary measures are the foveation time and the expanded nystagmus acuity function. So the foveation time is the period for which the image of an object rests on the fovea, as the name describes. So this is the documentation of nystagmus in all the 9 gazes graphically. So, coming to the surgical part, so the surgical principle is, the main principle is that the extraocular muscle surgery for correcting the abnormal head posture, that is achieved by shifting the null point closer to the primary position. And this is the principle on which the Kestenbaum procedure is based upon. So for the face turn, especially the horizontal face turn, we have Goto, Kestenbaum and Anderson procedure. So Goto advocated resecting the yoke muscles. Anderson advocated the recession of bilateral yoke muscles. And Kestenbaum is recession and resecting all the 4 horizontal muscles. So how are we going to recall this in our exams? That as the name suggests, under the sun. So under the sun, what is going on? Recession is going on. So under the sun, Anderson advocated the bilateral recession. Similarly, if we remove the O alphabet from the word Goto, we are left with goat, and bakra to halal hi hoga. So Goto advocated resecting the yoke muscles. And the Anderson is both recession and resecting all the horizontal muscles. So let's say we have a null zone to the right. So the patient will assume a left head posture. So what we have to do is, we have to, in Anderson, we have to recess. So what we are going to recess? We have to recess the overacting muscle, that is right lateral rectus and the left medial rectus. Similarly, in Goto, we have to resect the yoke muscles. In right, let's say in left face turn, we are going to resect the right medial rectus and left lateral rectus, which are underacting. Kestenbaum advocated both recession and resection. Then there is Park's modification. So instead of 5 millimeter Kestenbaum procedure, they advocated this 5, 6, 7, 8 plan. Then the Calhoun and the Harley procedure, which augmented the Park's procedure by 40% and 60% respectively for 30-degree and 45-degree anomalous head posture. Similarly, for vertical Kestenbaum, this is also based on the similar principle. And what we have to remember here is that when the chin goes up, the eyes roll down. And when the chin goes down, the eyes roll up. Okay, so for chin elevation, that is when chin goes up, eyes roll down. That is inferior rectus is overacting. So we have to recess the overacting muscle, that is inferior rectus, and resect the underacting muscle, that is superior rectus. Similar way goes to chin depression. Similarly, in cyclovertical anomalous head posture, surgeries are done to recreate the torsional direction created by the patient's head tilt. So we can achieve this by vertically shifting the horizontal recti or by horizontally shifting the vertical recti. So let's say there is a head tilt to the right shoulder. So whatever the patient is achieving, we have to recreate by the surgery. So right lateral rectus is going down, so we have to shift it up. Medial rectus is going up, we have to shift it down. Similar goes to the left eye. And similarly, we can do the horizontal shifting of the vertical recti muscle. And the other surgical procedure are the posterior fixation or Fardin's procedure, and the last procedure is supramaximal recession of all the horizontal recti. That is na rahega bans, na bachegi bansuri. We have done the supramaximal recession of all the horizontal recti muscle, which leads to reducing the amplitude of the nystagmus. So thank you.
Interesting.
Thank you, Phil.
Say topic is boring and difficult. Always, if you are in a classroom, make the topic funny and attractive. Remember it.
Yes, sir.
Which you did. I like that. Especially the GOAT acronym was great.
Thank you, sir.
Yeah, and tomorrow we'll meet for my class.
Yes, sir.
We'll build on this now. Thank you.
Thank you, sir.
Speaker, is it?
Nupur.
One more speaker? Oh, please carry on.
Good evening, everyone. So everyone here must agree that college days are the most fun and memorable time for us, and same goes with the friends. These college friends become friends for life. My best friend would participate along with me in most of the events and sports, but she would step back in any stage events. Reason? Not stage frightened. But the reason would be inferiority complex caused by the social stigma of blepharospasm, leading to the unwarranted anxiety. I, Dr. Nupur Jain, DNB resident from Raj Eye Hospital, Gorakhpur, would like to take this stage to shed light on this critical topic, blepharospasm. So this is how we would understand, learn and answer in our examinations. So what is blepharospasm? Blepharospasm is involuntary closure of both eyelids. Benign essential blepharospasm is a bilateral condition and a form of dystonia characterized by episodic contraction of the eyelid protractor muscles, which include orbicularis oculi, procerus and the corrugator superciliaris, and is not associated with another disease. Coming to the age, most commonly occurs in the age group of 40 to 60 years, rarely seen in children and adolescents. Female is to male ratio is 2 to 4 is to 1, and the prevalence is around 5 to 10 from 1 lakh population. Coming to the etiopathogenesis, the mechanism underlying benign essential blepharospasm is not yet clearly understood. There are various proposed mechanisms which include basal ganglia dysfunction, overactivity of the 7th nerve, leading to simultaneous forceful contractions of the eyelid protractors and retractors, ion channelopathies, and sensitization of the trigeminal system by photophobia. Coming to the risk factors, various risk factors include head or facial trauma, family history of dystonia or tremors. Reflex blepharospasm is reportedly triggered by severely dry eyes and blepharitis, intraocular inflammation, meningeal irritation, light sensitivity. Stress may exacerbate BEB, medications such as used to treat Parkinson's disease, etc. Signs and symptoms begin as mild and infrequent twitches, progresses over time to forceful and frequent spasms of the eyelids which abate during periods of sleep. In advanced cases, these episodes can cause functional blindness from periodic inability to open the eyes. Blepharospasm is associated with facial grimacing in Meek syndrome, and reflex blepharospasm may be accompanied by photophobia and ocular signs of blepharitis and surface diseases. This is the patient of blepharospasm. We can see frequent, forceful, involuntary contraction of the eyelids. Yes. Coming to diagnosis, the diagnosis is clinical and is made by careful history taking and physical examination. Coming to differential diagnosis, there are various differential diagnoses, listing out eyelid myochemias, secondary blepharospasm due to ocular irritation such as dry eyes, blepharitis, entropion, intraocular inflammation, photosensitivity, Meek syndrome, as a symptom of systemic diseases associated with lesions of brainstem and basal ganglia, facial tics, hemifacial spasm, cerebral palsy, functional focal seizures, etc. Coming to the treatment. The first line treatment would be periodic injection of botulinum toxin A. The patients carry a very good prognosis of 90% responsiveness. Second line treatment would include treating the ocular surface diseases like using eyelid lubricants. Oral medications are rarely effective, such as muscle relaxants and sedatives. Use of tinted glasses, reducing stress, and some studies have suggested improvement of spasms with methylphenidate, although additional control studies are needed. Coming to the surgical treatment, surgical myectomy of the orbital and palpebral orbicularis muscle in the upper eyelids, surgical ablation of the facial nerve are effective in treating BEB, but the latter has been discontinued because of the high recurrence rates. Surgery in patients with apraxia of eyelid opening may require a frontalis suspension to help initiate elevation of the eyelids. These are the frequently asked questions that, is there any way to prevent BEB? No, we cannot prevent BEB, but we can give symptomatic relief by reducing stress or treating any ocular diseases if present. How long do Botox injections for blepharospasm last? The onset of action is from 2 to 3 days, which peaks to 7 to 10 days, and the onset action continues for 3 to 4 months. Is it safe for people with blepharospasm to drive? People with severe blepharospasm having long duration of closure of eyelids and increase in frequency, it is not safe for the people to drive. Coming to the conclusion, symptoms of BEB can progress to render a person incapable of activities of daily living, such as reading and driving, and cause an unwanted cosmetic effect. The psychological distress is a real part of the disease, and patient education, counseling, and support is as valuable as medical treatment. This would be my small attempt to address this disease, make the big splash, spread awareness about the disease, and this is for my best friend and other friends in the globe. These are my references, and I welcome any questions if any.
You know the rules of the power presentation.
Yes.
That is the basic. What is the background of the slides? What is the heading to be given? What is the, you have write down the total theory. There are points, bold structures, and the minimum of the theory to be taken.
Okay,
so that's why that is, you make
It's
this
a very
topic.
crowded slide. We should have only
Okay, sir.
key points
Okay.
and few bullets with 4 or 5 words in each bullet. That's
Sure.
the rules of the game. So to say, you are but factually very correct and very exhaustive, and that way it was good, but the definition itself went awry because you talked about blepharospasm in the beginning and then you ended up with benign essential blepharospasm, and your definition was of essential blepharospasm. So your header should have been essential blepharospasm, because any blepharospasm, it could be acquired, and you have told it's idiopathic, isn't it? Okay, good.
Yeah, but in a given time, such short duration, you covered it very well. You covered it exhaustively, so well done.
Thank you, sir. Thank you.
While we are just computing the result, I'm sure you'll agree that the choice of the topic, right from there to confidence of presentation to the slides, everything was top class. It was really very well done. So congratulations to all the presenters for their effort. And I'm sure this kind of experience would help you as you go along in your career.
And all of you come for a photograph on the stage.
Result too.
नहीं, सबको ले लेते हैं.
Result, tell the result. I'm sure many of you would have guessed it. Do you all have micro teaching in your syllabus? Normally, postgraduates are supposed to go through micro teaching, which will tell you the rules of doing a PowerPoint presentation.
All right, so we have the results ready, so I'll not keep you waiting. Number 3, with just by a narrow margin, I mean, she was very close to number 2, is Dr. Anushri Lingaya for a topic granite or cataract. At number 2 is Dr. Charu for a topic surgeon's playfield, the limbus. Any guesses for number 1?
Yes,
Any guesses from the audience?
No, remember one, I think.
Number
first
1? Yeah, you can say my
Yes.
nystagmus. There's no harm in that. No, you should. You can. I'm
Yes,
saying you
you
can.
can.
Yeah. Any other guesses? All right. So we liked, as I said, we liked a lot of topics, and a lot of presentations came quite close. But at number 1, once again, I know she did very well in AIS Patna as well, is Ashwita on a topic, let's play Pictionary.
She chose a good topic and presented.
What happens though is that since Ashwita already won yesterday, so for the Star of iFocus competition,
Yes.
it would be Charu, who now represents in Star of iFocus, the teachers of teacher competition. Thank you so much, sir. I know it has been a long day, but thank you for your patience and all the knowledge and wisdom that you imparted.
Thank you also to you.
Could we please have everybody for a photograph with all the winners?
Invite all the candidates on the dais, so that's why we can take a group photograph of today's competition.
And tomorrow we start the session pretty much bang on time. So please, like in the morning, today also we started the session at 8. It's kind of your loss if you're in transit. So please be there on time.